Hello, everyone. Good evening and very warm welcome to our MedExpert session. This is Endocrinology. This is your mentor, Dr. Moses, and very nice to see you all. And I believe all of you can hear me loud and clear. And especially very warm welcome to people who have joined our course for our 2024 March session. We welcome you all from the bottom of our heart, and we are ready to do everything for you guys to make sure all of you pass 100%. That's what our dream is. And a couple of things I want to tell to people who have just enrolled in our session, especially who have enrolled for our 2024 session. Okay, we're going to have a lot of sessions, and we will be dealing a collective subjects, and cardiology, clinical form, the MCQ part. Okay, the MCQ part, and geriatrics will be dealt by Dr. Haynes. I hope all of you know he's an upcoming MRCP examiner, and he's a clinical cardiologist, a very famous cardiologist, and he has won so many national awards. Okay, and your endo, your ID, your endo, your ID, your neurology, your psychiatry, and your ophthalmology, and as well as your dermatology. This will be taken care by myself, and the rest of the subjects, that is your gastro, your rheumat, your RS, your onco, your hemat, will be taken over by Dr. Hura. She's an excellent internal medicine practitioner, and as well as she is a good teacher as well. So we three of us divided the subjects into this format, and I wanted to tell you something like how to approach this. Okay, I request all the new students, after taking the lecture, after listening to the lecture, or while listening to the lecture, please take notes. Please take notes whenever it is relevant. Okay, and immediately start working out Q bank. Then the next thing you should be doing is working out of Q bank. All right, and whatever questions you are going wrong, please note it down. Please keep one note, or at least a couple. Like my way of approaching is this: I get a 5-subject notebook, and the first column I write endocrine, I'll write the lecture notes, then I will write down the MCQs, whichever I'm going wrong. Again and again I will revise. Then once you're done with that, just go for mock test, especially with the past papers. That's it. There is no rocket science behind this. This endocrine lecture is far more updated, so we are going to cover a bit more extensively than what we had covered previously. Okay, we are please kindly mute the mics. Moderator, MedExam expert, please mute the mics of other candidates. I humbly request you, please do it. Okay, there will be a setting, mute all the audience. It will be terribly disturbing to us, and yeah, kindly mute. Okay, this is one thing. And one more news, I don't know how many of you will appreciate this method. After talking to a couple of people, and I suggested this. Okay, my suggestion, this is my suggestion to MedExpert, and I'm openly asking because a lot of students are here. Around 30 candidates are here with us, 30 doctors from different backgrounds. So what I suggested and what basically I wanted to do is work out of entire past medicine, past test, MCQs by myself for you all. Okay, and no, doctor, pharmacology only MCQs will be taken, because my sessions covered almost everything in the theory. There is no point in again taking a theory for you. That will only waste the mentor's time and your time as well. So he will be covering some MCQs for you, pharmacology. That's done. So, okay. So what my suggestion is, I suggested the management, I'll be sitting and working out entire past test and past medicine MCQs by myself with you all. And I believe many of you will be definitely benefited, because many of you got stuck up when it comes to working out MCQs and learning theory. Both are entirely different aspects of learning. So that's what my plan is for this batch or future batch. I mean, like, once the endocrine lecture, this lecture is over, then full pass test and full pass medicine. Every single question, I think in endocrine, if you take both, it will come around 600 MCQs. I wanted to sit and work out the entire 600 MCQs with you all. 600 entire MCQs. For that, each and every subject, I wanted to personally, even if the other mentors are busy, wanted to sit and do that. But I don't know how the management is going to take over from that point of time, whether it's their call to make it work. But I wanted this to happen, because once after the lecture, once you guys work out MCQs and come back and listen to my lecture where I'm going to work out all the MCQs without leaving a single MCQ, then it is going to definitely benefit you. Then later time, towards the exam time, I can do the last 5 years, around 15 past papers as well for you after you work out the MCQ, so that you miss out nothing, and there shouldn't be any excuse, and no one should tell I failed the exam or anything. Because if we are going to work out this manner, I don't think there is any excuse for anyone to score less marks or fail, because this will cover almost everything. Okay, and our lecture covers extensively more than what can, like, what past test or past medicine covers as well. MRCP Ireland people, and just give us some time. I'll pull in one more person and we are talking to them. We will try to get your past papers as well at the earliest. Okay, I'm asking the people to do, because myself, I'm not able to do many things, because I'm totally just like involved in PACES teaching, to be honest. Okay, and I'm just little bit like running around to videotaping some patients, and this month I've been just like stuck up with some other things in the family as well. That is one of the reason I'm not able to fully concentrate on that. But certainly, MRCP Ireland people, we are with you. We are going to do things for you. Okay, so this is how you guys are going to study. This is how the lectures are going to be taken. This is my suggestion to work out entire past test and past medicine MCQ for all of you. Each and every MCQ. It would be a tough MCQ or a simple MCQ, whatever it is. Entire bank, the latest bank. And I am not sure whether it's going to be implemented now or later, but this was my suggestion to them. At least keep a separate session where I can sit and work out the entire Q banks for you, so that you guys will be absolutely in a safer side when it comes to going to the exam. Otherwise, that's it. We are going to go to our lecture that is endocrinology. Endocrinology can be little tricky if you don't understand the basics. If you understand the basics, this endocrinology is going to be just a cakewalk. And some of the subjects can involve extensive biochemistry. Some will involve some complex algorithms. And another thing I want to tell about endocrinology is 50% of endocrinology is equal to diabetes. At least 50% questions you are gonna get is from diabetes mellitus. So I believe most of you people will be knowing what is a diabetes mellitus, how to manage it. Still, we are going to cover that extensively. All right. And this updated lecture, we have added some other important topics here, especially the topic of electrolyte imbalance. We are going to start with it. They are very dry and very frisky subject. This lecture can go up to 3 to 3.5 hours from now. Okay, please try to stay awake. Please grab a cup of coffee or tea, whatever it is. I'll try to wind up by 3 hours. Already 30 minutes, almost like 10 minutes have passed. I'll try to wind up by 3 hours to 3 hours 15 minutes. But I want to take each and every part of it without missing anything, because our coverage is not based on this past medicine notes or anything. We cover extensively, and we cover based on NICE guidelines, sign guidelines, and for approach, we use up-to-date Europe. This is how we approach any case or any topic. Okay, without wasting any time, I'm gonna start with the very first topic, that is electrolyte imbalance. Okay, electrolyte disturbances. The very first electrolyte disturbance we are going to see today is hyponatremia. Okay, there are questions that came in both part 1 and part 2. All right, part 1 and part 2 on the basis of hyponatremia. So we need to know what is a hyponatremia, what is the latest and standard definition. When the sodium concentration falls less than 135 millimole, it is hyponatremia. This is a very common thing you will encounter in day-to-day life. All right, even if you gonna be in the hospital, there may be a guy who's having some profuse vomiting or profuse diarrhea. He will be brought up. You can measure his sodium level can be on the lower side. So this is called a hyponatremia. So how we have to approach hyponatremia? If you know things clinically and if you have a very strong core concept knowledge and core basics, then whatever MCQ comes, you'll be able to answer. My wish and my dream is not just making you answer an MCQ, but making you a doctor who is eligible to treat patients as well. Because hyponatremia is not just what you're going to encounter in a OPD, you can also encounter in the critical care medicine as well. All right. So what and how we divide hyponatremia? Hyponatremia can be divided into 3 types. Okay. Just don't get worried and don't get worked out seeing these complex tables. I am going to make it as simple as possible. Okay. The first type of hyponatremia. Okay. The very first type of hyponatremia is hypovolemic hyponatremia. What is hypovolemia? The name itself says, okay? The name itself says hypovolume, decrease volume of what? Total body water. So how this happens? Okay, how this happens? This can happen. How you lose your body water? By vomiting, yes. If it goes through the back road, diarrhea, yes, it can cause. If there is any renal loss, for example, somebody is having somebody is having a uncontrolled blood glucose, what happens? That guy goes and hits the washroom multiple times, keep on peeing diluted urine, he will lose. That's a renal loss. If they are taking excess diuretics, yes, it can cause. So anything that causes loss of water from the body and causing hyponatremia is a hypovolemic hyponatremia. I hope all of you clear. First we will see this, then we will go to the next type, then third type, then we will see the investigation, then we will see the management. Okay, so hypovolemic hyponatremia can be due to 2 things. Okay, it can be due to urinary fractional excretion of sodium more than 20 and less than 20. If the fractional excretion of the sodium is more than 20, if you find an MCQ like that, this gentleman admitted in the ICU for so and so, his fractional excretion of the sodium is more than 20. What could be the following cause? They can give A, B, C, D, E. They can give vomiting, they can give diarrhea, they can give pancreatitis, they can give burns, and they can also give a diuretic excess. Okay, always remember, if the fractional excretion of the sodium is more than 20, these are the causes. It can always due to be a renal loss, means as sodium is pushed out from the body, it can be due to renal loss. Diuretics can push it out, and mineralocorticoid deficiency can cause that. Salt wasting or salt losing deficiency, anything can cause that. Renal tubular acidosis, metabolic alkalosis, ketonuria, again diuresis, osmotic diuresis, cerebral salt wasting syndrome. These will be the cause. Always remember, make it very simple. This concept may be reinforced for you in the nephrology section, but still I want all of you listening here to be very, very careful and make sure you are clear with this concept, okay, before we moving on to anything. If the fractional excretion of the sodium is less than 20, there is always going to be certain things that can cause. With case of a hypovolemia, that can be due to a vomiting, diarrhea, or a third space loss like a burns or a pancreatitis or a trauma. Okay, this is hypovolemic hyponatremia. Always remember, hypovolemic hyponatremia. The second type is where there is no loss of water. The patient may not have any diarrhea, the patient may not have any vomiting, the patient may not be taking any diuretics, the patient may not be losing any bicarbs, the patient may not be having any salt wasting, but still the patient's sodium level will be low. Okay, here rather the total body water will be increased. How it happens? Here, if you find the fraction excretion of the sodium can be more than 20 here. But how it happens? With the normal total body water, they will ask you in the MCQ, with the normal total body water, fraction excretion of the sodium is more than 20, then you can be sure this is a euvolemic hyponatremia. In what condition this can occur? Hypothyroidism. This MCQ has been asked recently last year. Okay, that's why I'm stressing this. I don't want to just teach you complex things to make you work efficiently in ICU or in wards. This MCQ has been asked. This gentleman, so and so they mentioned, then they said the patient is euvolemic, there is no edema is there, but the total body water is increased and fractional excretion of the sodium is more than 20. Which of the following can be can be one of the causes? They gave mixed options from all the table, and one of the option is hypothyroidism. Okay, one of the option is hypothyroidism. Then stress, some drugs, and SAIDH can cause this form of hyponatremia, that is euvolemic hyponatremia. Got it? The third type of hyponatremia is hypervolemic. There is increased body water and increased sodium, but still the patient may have low plasma sodium. Why? What happens in that case? It can be due to acute or chronic renal failure or nephrotic syndrome or cirrhosis or a cardiac failure. Just remember these three things. Okay. Hyponatremia, you know what are the types and how to divide that and what are the causes. This thing you should be knowing, because MCQ has come last year. All right. Now, some of the golden points on correction of hyponatremia. If the MCQ is going to come or asked in a way, how do you correct that? This has been asked once in the basic sciences. Total sodium deficit. What is the formula to calculate total sodium deficit? The formula is, you have to remember, there is no other go, because they are even asking in NHS interview. Body weight into 0.6 into multiplied by expected sodium minus measured sodium. This is how we do. And always remember, hyponatremia correction should not rise more than 10 to 12 millimole per 24 hours. Any enthusiastic or rapid correction of sodium can lead to seizures and central pontine myelinosis. This has been asked as an MCQ again. That's why I'm stressing you. The scenario came, senior house officer, on seeing some patient with low sodium, infused him with 3% hypertonic saline, and the patient suddenly started developing seizure and coma and weakness and GCS drops. What is the diagnosis? Central pontine myelinosis in case of a rapid correction of sodium, which will lead to CPM, central pontine myelinolysis or myelinosis, whichever you call it. And you should also know indications for 3% saline, that is not hypertonic saline. It can be given in case of any patient with hyponatremia with seizure, a low sensorium, or a very low sodium, that is 120 milliequivalent and lesser. In these three cases, you can give 3% saline, that is hypertonic saline. Okay. What are the investigations you should know in case of hyponatremia? Always you take, first thing is urine osmolality. This helps in differentiating between impaired free water excretion and primary polydipsia, because if urinary osmolality or osmolarity, whatever you call, is less than 100, then it is always primary polydipsia. Very, very important, because these questions can be literally confusing you, especially the difference between primary polydipsia, because earlier days, when they are going to ask you any question on primary polydipsia, they give in MRCP-1, they give all the 3 volumes. Okay, all the 3 parameters they give you. What are the 3 parameters? Plasma osmolarity, urinary osmolarity, and what happens after desmopressin. These days, they are not giving anything. How many of you have recently attended examination and you would have known the questions nowadays being asked are very ambiguous? Okay, the questions recently that has been asked are very ambiguous. Hardly 1 or 2 details are there, and they expect you to answer some question. So the clue can be hidden something very simple like this: urinary osmolality less than 100. You have to think what can be the possibility is primary polydipsia. If it is more than 100 milliosmol, it indicates an SAIDH. Then urine spot sodium, it again differentiate between hypovolemic hyponatremia and SAIDH. If it is less than 20 to 40, then it is SAIDH or diuretic use, and less than 20 to 40, 20, it is always going to be hypovolemic, that is renal conservation. These 4 points I want you to know, especially this point is very important. Recently, we had an MCQ on this. Then serum osmolality, you can measure high serum osmolality could be due to hyperglycemia, where we call it as a pseudo-hyponatremia. The serum osmolality is so high and still the patient's sodium, measured sodium is low, then you have to think of pseudo-hyponatremia as well. All right. Then raw serum osmolality is always a true hyponatremia. That's one point I want you to learn. Nothing much here. I hope now you're clear about hyponatremia. What are the types of hyponatremia? What are the tests you need to know? How to measure total sodium deficit and indications for hypertonic saline, and what happens when rapidly if you try to correct a patient with decreased sodium. These 3 points and this fourth point and this 5th slide is very, very important. That's all I want you to know, because this is important in 2 aspects. In your clinical aspect, it is important. The next aspect, it is very, very important, is MCQs has been asked in last year in all the 3 different diets. It has been asked both in MRCP and MRCP Ireland as well. That's why I'm stressing you to make sure none of you misses it out. All right. Now, another electrolyte imbalance which you need to know is hypokalemia. Okay. Hypokalemia is something again we can encounter. It's not as common as hyperkalemia these days, but still you can encounter. So what are the causes of hypokalemia? It can be GI loss. It can be renal loss, especially diuretics that does not spare potassium, like loop diuretics. Cushing syndrome can cause hypokalemia. Bartter syndrome, Liddle syndrome, these are the causes of hypokalemia. Again, it can be also due to redistribution. Okay, if this is a cell, cells are always bags of potassium. Cells has potassium in and sodium out. You know sodium, potassium, ATPase. But if you give drugs like insulin, what insulin does is insulin takes the potassium and it pushes the potassium into the cell. So in such a patient, if you are going to measure the potassium levels, it will be always low, because insulin tends to move and keep the potassium inside the cell. And any misadventure with bicarbonate therapy, because some doctors may not know how much fluid to give, how much fluid not to give, and their knowledge of fluid can actually put the patient in jeopardy. I have seen these things happening in the clinics. They are too hesitant to ask the seniors or anyone, what should I do? See, trust me, when I first joined in as a junior doctor, I had a lot of doubts. I never hesitated to ask even to a nurse, this is happening, sister, what can we do? There's nothing wrong in asking. But a lot of people, especially during this dengue times and all, they just use the fluid injudiciously. So any injudicious bicarbonate therapy like that can lead to hypokalemia. Any alkalosis and periodic paralysis, all these things can cause hypokalemia in a patient. Now we need to know how to manage hypokalemia. Always you should start potassium replacement through peripheral lines, because through central lines mostly, because in peripheral lines what happens is it can cause thrombophlebitis. Always remember. So you have to dilute with normal saline. First point I want to know. Okay. If you give through the peripheral line, the potassium can cause thrombophlebitis. Remember, so you have to dilute. Central line you can give in ease, but it's not possible all the time. Okay, patient tolerating orally can give a KCl syrup of 10 ml stat. Potassium chloride can give 10 ml stat and repeat every 2 hours. This is again very, very important. And the point I want to stress on, where MRCP questions has been asked, is the 3rd point. Hypomagnesemia often coexist with severe hypokalemia. Always remember, in all sort of depleted potassium for part 1 and part 2, very frequently this has been asked. There is always a component of hypomagnesemia along with the hypokalemia. So always add a magnesium containing infusion. This 3rd point is very important in exam point of view. Even if you forget all the points in the slide, please don't forget this one point. Okay. Please don't forget this one point. And patient on any long-term diuretic therapy can also have hypokalemia. This may aggravate digoxin toxicity. Correct hypokalemia aggressively on patients with digoxin therapy. This is again very, very important. This concept has been tested in MRCP-1. Which of the following can precipitate digoxin toxicity. They will ask you hyponatremia, hypernatremia, hypokalemia, hyperkalemia, hypocalcemia. You shouldn't get confused at the time. It's always hypokalemia that is going to precipitate digoxin toxicity. Hypokalemia, digoxin toxicity. Don't forget. Also, don't forget, hypokalemia also is associated with hypomagnesemia. So even if you measure magnesium or not, always add magnesium. If the patient can take it orally, give oral magnesium. All right. After correction, you can prescribe syrup till the next outpatient review. All right. In this slide, again, I'm telling you 2 points, very important. Hypokalemia can precipitate digoxin toxicity, and hypomagnesemia is always associated with hypokalemia. Then comes the most important thing. Okay. After this, we are going to go and discuss some interesting endocrine cases. Hyperkalemia. Okay. What are the causes of hyperkalemia? This is something very frequently we can encounter. All right. It can be due to increased intake. You know, the potassium-rich foods, right? The spinach are very high in potassium. All right. Spinach. You know, all these red bananas. All those things are like very high in potassium. Or it can be due to reduced excretion, renal failure, hypoadrenal state. All this can cause. And drugs. Everything, every line in this slide is very important. Questions has been asked. That's why I'm telling you. ACE inhibitors, ARB, potassium sparing diuretics like your spironolactone, lacilactone, which we use here, and NSAIDs, cyclosporin, tacrolimus, trimethoprim sulfamethoxazole. This has been asked in MRCP MCQ. The patient who has some infection, he has been put on some antibiotics, and all of a sudden his potassium levels has been raised, they asked. So they asked, which is the culprit drug here? They gave 4 or 5 antibiotics, and one of the answers is trimethoprim sulfamethoxazole. This Bactrim or Septron, whatever you call, this drug is another culprit drug that can raise potassium levels. Another thing that can cause is acidosis and tissue damage, such as your rhabdomyolysis. This is again very, very important. All right. Then pseudo-hypokalemia due to hemolyzed sample. Very important. What are the causes of hyperkalemia? You should be knowing. Next, what are the ECG changes in hyperkalemia? This is very important, especially for part 2 and as well as part 1 people. For part 1 people, the thing is they will at least tell you there is a peaked T wave or wide PR interval and wide QRS, there is sine waves, at least you will know. For the part 2, they will put some waves like this. Then you have to see and you have to know this is a sine wave. Unless you haven't seen, you won't know anything. That will appear like some atrial fibrillation or atrial flutter. All right. So what are the ECG changes in potassium imbalance? First thing, hypokalemia, there will be always depressed ST segment, and T wave can be diphasic like that. T wave is always monophasic. T wave is like that, right? It can be diphasic, and there is always going to be a prominent U wave. And this is a normal ECG. And as the potassium level increased, it can show tall peaked T wave like this, and the PR interval can wide, and QRS interval duration, see, it has become wide. This is a tall peaked P wave. And the hyperkalemia increases, the potassium level increases, it will lead to loss of P wave, and you will get a wave like this, which I drew here. This is called as sine wave. If you see sine wave, immediately you have to start managing the patient, because the patient may go for a cardiac arrest. All right. So how do you treat hyperkalemia? There are 3 steps in the management of hyperkalemia. Okay. Step 1, step 2, step 3. First thing always is a cardio protection, which is more important. You have to protect the heart immediately. So you're going to give 10 ml of 10% calcium gluconate over 4 minutes. Doctors, this dosage you have to remember, because this has been asked in MCQs about in multiple question papers. Okay. And again, intracellular shift, that's the second thing. First, you protect the cardiac myocardium. Okay. How you protect the myocardium? By giving calcium gluconate 10 ml of 10% over 4 minutes. Second is intracellular shift. You have to push the potassium into the cells. Okay, these are the cells. This is the potassium. There is a lot of potassium is there. You have to push it back to the cell. How you can achieve it? By giving salbutamol nebulization 5 milligram every 15 minutes, 3 doses, and also 50 ml of 50% dextrose with 8 units of short-acting insulin over 10 minutes. Okay, if the blood glucose is too high, only give insulin. Third step to decrease the potassium from the body is elimination from the body. How are you going to eliminate? By giving loop diuretics like furosemide or potassium binding resin. If nothing works out, for example, they are giving a question scenario, the patient potassium levels are still 6.5 or 7, calcium gluconate has been given, insulin with dextrose has been given, or salbutamol has been given, a loop diuretic has been added, Lasix has been put, and still the potassium levels are still high. Last resort is your nephrology department, that is your dialysis. Immediate dialysis through a central line is the only thing that is going to save the patient. Okay, I hope now all of you are clear, having basic concepts and understanding are on 3 things, that is hyponatremia, hypokalemia, and hyperkalemia. These 3 things are very, very important. And there is one more electrolyte disturbance that has been asked is your hypercalcemia, which we will see in some time later. Okay, because if I'm gonna keep on teaching this electrolyte imbalance, that will be like a beja fry. That will be like almost equal to frying your brain. I don't want to do that. Now we are going to some other important concepts and some interesting cases and some MCQs and some pictures, some patient videos to keep us light. All right. HPA axis disorders. Before we going into the HPA axis disorder proper, you should know hypothalamic pituitary axis hormones. You need not know this entire table. This entire table is for someone who wants to do CCT endocrinology or appearing for specialty certificate examination in endocrinology. This has been taken straight out of Williams endocrinology textbook. I want you to learn few things here. Okay, the things that has been asked. This is the first thing I want you to learn. What is a type? What is a hormone? The second thing I want you to learn is what kind of hormone it is. Third thing I want you to know is what stimulates that particular hormone. Fourth thing I want you to know is what inhibits the particular hormone. The fifth thing I want you all to know is what is the target. And sixth thing, what it does. 1, 2, 3, 4, 5, 6, you should know, because this can be asked in basic sciences. This can be asked in endocrinology proper. So it doesn't matter whichever column they are going to ask, you should be able to answer. That's all I want. Okay. The first hormones we are going to know is FSH and LH. Okay. Follicle stimulating hormone and luteinizing hormone. What type of hormones they are has been asked. It's a glycoprotein hormone. It's stimulated by GnRH and your estrogen. Both stimulates FSH and LH. It is inhibited by sex steroids. Okay. Where is the target? You all know. It acts on your ovaries and testes. That is the gonads. So acting on that, what it does? It causes follicle growth and germ cell maturation. Done. The first thing is done. All right. First hormone. Second hormone is TSH. Again, what type of hormone it is? Glycoprotein hormone. Stimulated by thyrotrophin releasing hormone. Okay. It is inhibited by T3, T4. That is your negative feedback. Okay. TRH comes. It causes release of TSH. TSH will act on thyroid gland and produce T3 and T4. Once this goes in excess, it goes and inhibits TSH. All right. Clear? That is a negative feedback. Along with that, your dopamine, somatostatin, and glucocorticoids, again, all these things can inhibit the secretion of your TSH. Remember them because they may ask you an MCQ in the future. Because we all know T3 and T4 is going to negatively go and it causes a negative feedback loop and inhibit the TSH. But we don't know. Many of us, you may not know dopamine, somatostatin, and glucocorticoids can also decrease your TSH. Okay. Remember, target gland is your thyroid. It causes T4 synthesis and secretion. Then prolactin, again, it's a polypeptide. This has been asked multiple times. The inhibitor hormone of prolactin, or which hormone keeps the prolactin in check? The answer is dopamine, 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 dopamine. Don't ever forget it. Okay, don't ever forget it. All right, it acts on breast and other tissue, milk production, that you know. Then comes another important hormone called growth hormone. Okay, it is stimulated by growth hormone, stimulating hormone or growth hormone, releasing hormone. It is inhibited by somatostatin and IGF activins. It acts on multiple tissues, you know, liver, bone, and all the tissues. Okay, trophic effect, what it does? It causes IGF protection, growth induction, and it antagonizes insulin. That's why excess growth hormone, there will be always going to be insulin resistance. All right, you are clear with these hormones, all of you? That's all I wanted you to know. What are the hormones? What type of protein is that? Because they had asked once, growth hormone is a what type of hormone? Glycoprotein, polypeptide, and some other option. You should be able to know it's a polypeptide hormone. They had asked prolactin is inhibited by which of the following? Dopamine. That's the reason I'm telling you this table is important. Only know what I have pointed out. Just take notes of it and learn. That's more than enough. We'll go to the very first case today. A 16-year-old girl presents with primary amenorrhea, galactorrhea, mild headache. Ophthalmological examination reveals loss of vision in the right eye. Here is an MRI. If you are a part 2 student, you will get. Just think and tell me what could be the possibilities. Primary amenorrhea, galactorrhea, mild headache. You can answer in the chat box. Please don't unmute your mics and answer in the chat box. If you are getting a patient like this, what it could be? Fantastic, yes. It's a pituitary adenoma. It's a pituitary adenoma. Definitely a macroadenoma, right? Because, see, the tumor is huge and it is causing a visual loss. Probably one of the subtype of pituitary adenoma is prolactinoma. Yes, exactly. A craniopharyngioma, pituitary adenoma, or a prolactinoma. Okay. Classification of pituitary adenoma. This is important. Pituitary has lot of cells. Okay, pituitary has a lot of cells. Okay, depends on which cell overgrow that particular adenoma will happen. If lactotropes, lacto means first always lacto is milk. You know, Latin and Greek are very commonly used terms that is used in medicine. If you know Latin and some of the Greek terms, medicine will be a cakewalk for you. Trust me. Lactotrope. The hormone product is prolactin. It can cause what? Galactorrhea and hypogonadism. Also know many drugs can cause galactorrhea. You should know the list of drugs cause galactorrhea. It's extensively covered in clinical pharmacology session, and Dr. Haynes will work out some MCQs for you in this session. Then another cell is your gonadotroph. Gonads. What are the two hormones? FSH and LH. If it can get hyperstimulated, it can cause hypogonadism. Then comes your somatotroph. This secretes your growth hormone. This will lead to acromegaly and gigantism. Then comes your corticotroph. If ACTH is increases in secretion, it's called Cushing's disease. I hope all of you know what is a Cushing's disease and Cushing syndrome. We will see it, don't worry about that. Then all the mixed stuff. And thyrotroph, if it secretes more, then TSH will go up, then thyrotoxicosis. These few things I want all of you to know. So always the initial treatment is going to be surgical resection followed by hormone replacement. I will explain each and every tumor. Okay, now we will see one by one of the case. The very first case is again a 52-year-old man presented with difficulty driving at night and reports not seeing cars coming from the sides. In PACES examination, we ask anyone when they have a visual loss or headache, we ask this question: are you bumping into objects? Or are you able to see cars from the sides? Means what? The patient is having bitemporal hemianopia. So both the temporal field loss, they won't be able to see the cars coming from the sides in the mirror or bumping into the objects. They will miss out the door frame and they will go bang on the door. Okay, he also describes progressive loss of libido and inability to obtain and maintain an erection, which started about 2 years ago. Again, like I said, he bumps into the objects, he gained weight, and for the past 2-3 years he is fatigue, he is unable to do the jobs which he used to do before. He has a high BMI and loss of muscle bulk and proximal arm muscle weakness and small bilateral gynecomastia with soft testicles and abnormal visual field with bitemporal hemianopia, like I said. This is a typical case they will give you, or this is the typical way a patient will present right in front of you. If that is the case, the answer is going to be again pituitary adenoma. Okay, always remember the overall diagnosis here is pituitary adenoma, individual syndromes which we are going to see. The very first syndrome I want all of you to know is Kalman syndrome. This has been asked in MCQ multiple times. We have to add some more pointers here than the previous batch. This is first of all due to defect in the synthesis of GnRH, very first point. And Kalman syndrome patients typically present with anosmia or hyposmia. What is anosmia? Patient won't be able to sense any kind of smell. What is hyposmia? Patient will be able to smell, but the smelling tendency would have been decreased or on a lower scale. So when you find this is due to typically an olfactory bulb agenesis. This is very common in case of Kalman syndrome. This has been asked in MCQs. The anosmia and hyposmia and Kalman syndrome is due to what? 5 options they gave. The actual correct answer is olfactory bulb agenesis. It is also can be associated with color blindness. These are the other presentations of Kalman syndrome. Nerve deafness, optic atrophy, renal abnormalities, cryptorchidism, and mirror movements. All these things. Okay, each and every word here is very, very important. All of you remember, each and every word here is very, very important. It can be due to color blindness. It can also cause color blindness. It can also cause nerve deafness. It can also cause cryptorchidism, mirror movements, same form of muscle movement on bilaterally it can occur, mirror movements, and renal abnormalities, optic atrophy. Because we expect Kalman syndrome means they will give some MCQ like the patient is not able to smell. They had asked this multiple times. If they want to think little differently, they may incorporate any one of the symptoms. So be ready. The classical thing, it is due to Cal gene mutation. The classical thing you will find is it has low LH and FSH. Many a time this is the differentiating pointer between Kalman and Klinefelter. Where Klinefelter, the LH and FSH will be very high. In Kalman, it will be low. Always remember, this is another MCQ point they had asked. Because patient may present similarly. In UK, we have something called Kalman clinics. That's a specialized clinics treating Kalman syndrome patients. That's called Kalman clinic they have in UK. The classical finding in Kalman syndrome is low LH and FSH. Long-term treatment is always you give male HCG and testosterone. It may restore the fertility and pubertal development. Okay. And gonadotrophin and pulsatil subcutaneous GnRH is another treatment option available. If they ask how do you treat a patient with Kalman syndrome, any options you can mark. They won't give all these options together, but you give HCG and testosterone and also pulsatil GnRH. I hope all of you know. I hope all of you today aware of the other presentations of Kalman syndrome. Okay. Next, other questions and other things, the topics that is coming in the pituitary is lymphocytic hypophysitis. This is again a very, very, very important thing. Okay, typically they will give a history of a postpartum women. Okay, this will seen as a mass that is resembling adenoma in MRI. Typically the history will be a postpartum women having some headache, visual disturbance, and typically they will classically give you elevated ESR. If you find anything like that, that's most likely a lymphocytic hypophysitis. Typically, you give glucocorticoid, completely it will resolve. In a postpartum woman with an MRI, there is a mass in pituitary in a postpartum woman with elevated ESR. Headache, visual disturbance can be common. They will give you this clue, elevated ESR. then it is going to be a lymphocytic hypophysitis. You have to give glucocorticoid, it will resolve. This is for part 2 people. This is how you will look. Part 1 people also kindly see it so that you will never forget. There will be terrible amount of lymphocyte infiltration in these patients. Lymphocytes will be infiltrating the entire gland. That is why we call it as lymphocytic hypophysitis. All right. Then comes another thing that is extremely important when it comes to pituitary gland is pituitary apoplexy. This can again occur in postpartum. That is what we call as Sheehan syndrome, because many questions has been asked in this. Many case scenarios has been generated based on this in PACES examination as well. And you should always know the risk factors for a Sheehan syndrome or a pituitary apoplexy. Diabetes mellitus, hypertension, and sickle cell anemia, and also shock. All these are risk factors. Okay. Diabetes, hypertension, sickle cell anemia, and shock. All these are risk factors. And there will be hyperplastic enlargement of pituitary gland during pregnancy. Along with your enlargement of the mammary gland and everything, pituitary gland also enlarges typically in pregnancy. When there is a hyper enlargement, increased enlargement in the pregnancy, it can predispose to Sheehan syndrome. How patient will present? Severe headache will be there. Signs of meningeal inflammation like vomiting, neck rigidity, all these things will be there. Visual disturbance will be there. Ophthalmoplegia can be there. Loss of consciousness and cardiovascular collapse. All these things can present. If you find in a postpartum woman, all this presentation, patient presenting with severe headache, nausea, vomiting, and neck pain or neck rigidity, visual disturbance, inability to move the eye on all the side, or painful eye movements, loss of consciousness, always think in terms of pituitary apoplexy. What is apoplexy? Apoplexy means bleeding within the gland. It means bleeding within the pituitary gland. And you should know the risk factors that are diabetes, hypertension. If you find any such case histories in your MRCP-1 or 2 MCQ, always think in terms of pituitary apoplexy. In a postpartum women, always think in terms of Sheehan syndrome. The treatment is urgent surgical decompression in severe cases. In severe cases, urgent surgical decompression is needed. Okay. This is pituitary apoplexy. Next, we go to another case. Here, a 45-year-old man presents with a loss of libido and some erectile dysfunction. He is otherwise healthy. On physical examination, he has mild bilateral gynecomastia, normal testes. Laboratory work revealed prolactin level of 4,600. A normal prolactin level are up to this. Okay, he has low testosterone, low LH, low FSH. So both condition occur in postpartum. How to differentiate? Which condition you are talking about, doctor? Postpartum, typically pituitary apoplexy is occurring. And one of the type of pituitary apoplexy is the Sheehan syndrome. Which other condition I am not getting you occur in postpartum? Okay. And this is a case challenge. Now, a person, a 45-year-old middle-aged man with loss of libido, erectile dysfunction, mild bilateral gynecomastia. Okay, lymphocytic hypophysitis. Okay, 1 second, I'll just answer this doctor's doubt. Doctor, lymphocytic hypophysitis will just present with headache and some visual disturbance. Okay, it won't present with an apoplexy finding. Apoplexy is what? Bleeding. Once the pituitary gland itself start bleeding, what will happen? The patient will present in a dramatic condition. Lymphocytic hypophysitic patient will not present to accident and emergency. She will come just to a normal ward walking and tell, I have some blurring of vision, I have some headache. On contrary to that, a pituitary apoplexy or a Sheehan's patient will land in emergency, because headache will be so severe, meningeal irritation signs like neck rigidity, and you're vomiting, nausea, and inability to move the eye, or painful eye movement, loss of consciousness. None of these things you will find in a lymphocytic hypophysitis. You're getting it? This is an emergency condition. This is an acute medicine scenario, whereas that is more of a general internal medicine handling scenario, where the lymphocytic hypophysitis, there will be some headache, some visual disturbance will be there. It won't be a dramatic presentation like a pituitary apoplexy. Also in pituitary apoplexy, you will also find BP going low. Patient will almost go on a cardiovascular collapse. In the shock-like features you will get. Okay, make sure you guys are very clear in this. No problem. Now, a patient, a middle-aged man present with the loss of libido and a very high level of prolactin, and low testosterone, low LH and low FSH level, what will be your diagnosis here? Of course, it is a prolactinoma, right? It is a prolactinoma. Okay, it is a prolactinoma. There is a lot of terms that are confusing people between a microprolactinoma, between a macroprolactinoma, and a non-functioning pituitary adenoma. I want to make things clear here with these 3 points. Okay, listen very, very carefully. Listen very carefully. Be alert. A prolactin level greater than 5,000. Remember the value. If you're taking notes, take notes. Usually indicates the presence of prolactinoma. Okay. Also, certain drugs can increase prolactin level. That is your risperidone and metoclopramide. Always remember clinical pharmacology. Go back to my lectures. I would explain what are the drugs that can increase the prolactin level. Okay. The prolactin level, if you find greater than 10,000, it is always macroprolactinoma. You find symptoms in the question, it's not there because lot of reports are coming after the recent MRCP exams. The reports are, we don't find a lot of things there. Like they are just giving 1 or 2 lines and asking the answer. Yes, it will be. But if you find something like prolactin level greater than 10,000, they may not give you the symptoms. They may just simply mention gynecomastia. They may not mention milk discharge and all. Go for the option of macroprolactinoma in that case. Okay. In any patient with serum prolactin less than 2000 and a macroadenoma, okay, pituitary adenoma greater than 10 millimeter on pituitary imaging, the diagnosis is likely to be non-functioning pituitary adenoma. Okay, non-functioning pituitary adenoma. Always remember, prolactin level can be less than 2000. Do you have to memorize the value? Better no. I am not asking you to memorize everything. At least know some range, 10,000, 5,000. That's not tough, right? You don't need to memorize everything. What happens in MRCP is some exam papers, they give normal value if they are in a good mood. In some papers, they don't give you any normal value. So if they don't give you normal value, who is going to be in trouble? We will be in trouble, not them. They will do just anything and go. Okay. So the drugs, you should know at least few drugs. You should know few drugs. If you don't know the drugs, then because they will give names of similar sounding drug. They will give metoclopramide, metronidazole, and they will give meropenem. So what you will know? If you, unless you know at least few drugs, the names will confuse. They will give similar sounding names. Like I said, one options came like that: metronidazole, metoclopramide, meropenem. In the exam tension, if you see that, you will be absolutely confused whether this or that unless you know the drug before. So you should memorize some drugs. There is no other option in clinical pharmacology. The best way to memorize is take notes and discuss with somebody who's preparing for the exam, so that it will eventually get registered in your mind. All right. This has been covered in clinical pharmacology. Extensively we have covered. So how do you treat a prolactinoma? In any asymptomatic case, it's always going to be observation. In patients with symptomatic microprolactinoma and who does not desire pregnancy, give dopamine agonist. Okay, you give dopamine agonist. That's the first line. So next they will ask, the patient has been put on a dopamine agonist. He or she is still not improving. It's the same. Then combined OCP. If still not improving, nothing is working out, transfemoral surgery. Still not working, radiotherapy. Okay, this is the sequential step we will do. Okay, always remember, any prolactinoma question they are coming, observation if there is no symptoms. Okay, you know the thing, don't trouble the trouble unless the trouble troubles you. That's what they call. Unless it's not troubling you, leave it as it is. All right, if it is causing some symptoms, first thing, dopamine agonist. Okay, second, combined OCP. 3, transfemoral surgery. 4, radiotherapy. They can ask you questions in any of these 3 options. They can tell, patient has been already put on dopamine agonist, already given combined OCP. What to do next? Transfemoral surgery. The patient put on dopamine agonist, combined OCP, transfemoral surgery also. What is the next step? Cellular radiotherapy. Simple as that. All the things follows the same this list. Okay, this is straight out of NICE guidelines. Okay, no need to get confused. You'll be able to diagnose now and you'll be able to treat as well. Now the next question. 32-year-old young lady presented with complaints of amenorrhea. Amenorrhea, I hope all of you know, primary and secondary. Primary amenorrhea is the patient never had any kind of menstrual cycle in her life. Secondary amenorrhea is the patient is or was having menstrual cycle and it stopped after some period of time, or any failure to lactate. Generalized weakness is there, and she had significant past history of preterm twin vaginal delivery, which is complicated by severe postpartum hemorrhage. The patient had circulatory collapse and shifted to intensive care unit and managed conservatively and received 3 blood transfusions. A generalized condition has been stabilized. Patient was discharged 8th day post-delivery. 1 year later, patient also with complaints of failure to lactate, amenorrhea. She also has generalized weakness. So the test has been done. Okay. USG of the pelvis reveal normal endometrial thickness, and diagnosis of Sheehan syndrome is made. This has been added. The diagnosis is Sheehan syndrome. Okay. Sheehan syndrome. Okay. So in part 2, they may put some MRCPs, this kind of MRI images where there is some bleeding in the pituitary gland. Okay. There's something called a bleeding in the pituitary gland. They may put, this is another case of Sheehan syndrome. Okay. Always remember, Sheehan is an acute presentation with circulatory collapse and all dramatic presentation. Okay. In postpartum women. Now comes to just what are the features of different tumors of pituitary, the size and common clinical features. Okay. Prolactinoma, microadenoma, size wise it is less than 10 millimeter. Macro means more than 10 millimeter. You will find galactorrhea, amenorrhea, hypogonadism, visual field defect, headache, and erectile dysfunction as well. You all know. Then acromegaly. We will discuss acromegaly extensively, don't worry. Okay. It causes change in appearance, visual field defect, and hypopituitarism. Cushing's disease, we will discuss. Nelson syndrome, this is due to post-adrenalectomy. Always remember, if somebody is presenting something like that, post-adrenalectomy, the word is there, go and mark Nelson syndrome. All right, go and mark Nelson syndrome. Rest of the tumors we are going to see one by one again. Okay, this is one of the table that compares the advantage and disadvantage of various therapies. Just it's better to know. Okay, and the thing I want all of you to know is adverse effect of radiation and surgery they won't ask, but adverse effect of medication they will ask. Okay, first thing is dopamine agonist. What are the adverse effect? Okay, lot of things. It can cause fibrosis, and it can also cause impulse disorders. Remember, somatostatin analog, gallstones. Okay, gallstones is one adverse effect I want you all to know. These 2 adverse effects, please remember. Dopamine agonist can cause impulse disorder and fibrotic reactions. Especially, it can cause cardiac valve fibrosis as well. And somatostatin analog, always remember, gallstones. Because they can give a history of gallstone, they can ask which of the following drug would have caused that. And one of the drugs that will be there in the option is octreotide. This is how clinical pharmacology is tested. Unless you relate and study, people will get into trouble studying clinical pharmacology, and they will keep coming and reporting, oh my God, I am not able to answer the MCQs. It is getting tough. You have to relate and study. That's it. Okay. Hormone replacement therapy is again very important. You should know what hormones to be replaced. In adrenal deficiency, hydrocortisone has to be replaced. For thyroid, levothyroxine has to be replaced. In gonadal hormones, in male, testosterone. In female, cyclical estrogen or progesterone. And HCG plus FSH 2 for fertility has to be given. In growth hormone deficiency, recombinant growth hormone is available. In case of any kind of thirst, that is, they are talking about diabetes insipidus like stuff, can give desmopressin. Okay. And breast, in prolactin is high, you can give dopamine agonist. These are the hormone replacement therapy. In general, we use. You don't need to remember doses. That's another thing. You don't need to remember doses for everything. But in certain thing which I highlighted and told you, where you have to remember doses that has been asked in the MRCP examination. Okay, that is hyperkalemia management. What dosage of salbutamol you will give, what amount of dextrose you give in what, that has been asked. So because they expect you to know that you are a safe doctor or an unsafe doctor. Entire MRCP test only these 2 things. You are a safe guy or an unsafe guy. If they give you a patient in your hand, will you be able to handle the patient safely or what? That's what they expect. Okay. Now comes to growth disorders, the next important topic in endocrinology. In growth disorder, this is the first case we are having. A 47-year-old woman with arthritic pain. Next, pain of the knees, hips, soft tissue swelling, and she has excessive sweating. She also noticed progressive enlargement of the hands and feet. She has been taking antihypertensive medication for the past 3 years. On physical examination, she has coarse facial features with prognathism and prominent supraorbital ridge, and tongue is enlarged and the fingers are thickened. Her husband says she frequently snores. Laboratory test reveals elevated IGF-1. What is the diagnosis? You don't need to read the entire passage. By now, all of you should know the diagnosis. Okay, just assume this is that lady. This is that lady. Just assume as it is. This is the lady. This is the lady. Can you see her? Can you see her? See the facial feature, how it is. See the lips. And see the spacing of the teeth. Yes, it is acromegaly. There is no doubt. It is acromegaly. Why she snores? Because the acromegaly patient always associated with OSAS due to tongue enlargement. That is obstructive sleep apnea syndrome. That will be taken extensively in respiratory medicine by ma'am. She will teach it very nicely. Don't worry. Obstructive sleep apnea syndrome. The patient will snore. As a result of the excess snoring and enlargement of the tongue, there will be obstructive sleep apnea syndrome. All right. So what are the causes of acromegaly? You don't need to remember everything. At least know what can all cause acromegaly. Okay. Growth hormone cell adenoma. This is one of the very important cause of acromegaly. That at least first thing I want all of you to know. Any growth hormone producing pituitary adenoma can cause acromegaly. All right. Then another thing I want you all to know is familial or multiple endocrine neoplasia. This is very, very important. We have separate slides on that. We will look at the multiple endocrine neoplasia separately. Then comes familial acromegaly, McCune-Albright syndrome, Carney complex. Whatever I'm tick marking is very, very important. Very, very important. Okay. Another is iatrogenic due to excess growth hormone, any lymphoma. Pancreatic islet tumor can paraneoplastic syndrome, secretion of acromegaly. Just remember what I had tick marked here. You should know. GHL adenoma, MEN1, familial acromegaly, McCune-Albright syndrome, Carney complex, pancreatic islet cell tumor, iatrogenic or lymphoma. Always you guys should be aware of the thing. Okay. Then how to diagnose acromegaly? A lot of people get confused when it's given. I'm going to make it very, very clear with this algorithm from up to date. Okay, it's very much simplified. Okay, you're going to take IGF-1. You're going to take IGF-1. If it is normal, no acromegaly, leave it. If it is equivocal, okay, lightly elevated, or if it is fully elevated, then you have to check whether the growth hormone is suppressed with a test called OGTT. This is the first step. If it is normal, it's okay. Second is, if it is equivocal, that is, it's neither too high nor too low. Then the next best step in that case is OGTT plus GH level. Okay. OGTT with GH level. Always remember the screening test is IGF-1. Okay. Once, if they ask you in the MCQ to confirm the diagnosis or the most appropriate test, always remember it's OGTT plus growth hormone levels. Okay, that's the next thing. If the growth hormone is suppressed here, okay, rule out acromegaly. If there is an inadequate suppression, go for pituitary. Suppose if it is too much elevated, okay, IGF-1 is excessively elevated and you are seeing the patient with full-blown features of acromegaly. Prognathism is there, okay, wide-spaced teeth is there, thyromegaly is there, Hoarse voice is there. Patient has excessive sweating. Why? Due to sweat gland hyperplasia. Acromegaly people are also prone to get colorectal carcinoma. All the features are there. Then straight away you can go ahead and take a pituitary MRI. All right, pituitary MRI. If it is normal, then you have to rule out any kind of paraneoplastic syndrome. If you find a mass, then it is an acromegaly. The treatment is always going to be surgical. All right, once again, how to approach a disease called acromegaly. How to approach the condition called acromegaly. Screening test is IGF-1. Always remember, if it is normal, acromegaly is ruled out. Don't worry about it. If it is equivocal or elevated, the next step, best step is to do a OGTT with growth hormone levels. If growth hormones are suppressed by giving oral glucose, then rule out acromegaly again. If it is inadequate suppression or the hormone is tremendously elevated, IGF-1 is tremendously elevated, go for a pituitary MRI. If the MRI shows a tumor, remove it. If the MRI is normal, okay, then check GHRH and as well as rule out extra pituitary acromegaly. I told you why it occurs. All right. Now all of you are clear. Okay. Next, how do you manage? There is a complex algorithm is here. Just at MRCP-1 level, just remember it's always transsphenoidal surgery plus follow up, because acromegaly can recur, because that is one of our presentation with myself and another endocrinologist and a neurosurgeon. We three of us are about to publish a paper in New England Journal of Medicine. We followed up patients who have underwent transsphenoidal surgery in the department of neurosurgery and ENT and who had acromegaly recurrence. It can recur. So you have to monitor. Okay. You have to monitor. How you monitor is monitoring with IGF-1. Okay. Then comes your MRI and all. Okay. Again, for monitoring, IGF-1. Screening, IGF-1. Always remember, if they asked about these two words, it's always IGF-1. This is the reason I told the management I want to work out all the past test and past medicine MCQs with all the candidates here. Then you won't go wrong if you are going to sit and work out the MCQs with me after a lecture like this. But I don't know how far that is going to be practically possible, whether the management will allow me to go on with that. Okay. Now, let's go to the next case. Okay. And do you guys need a 10 minutes break? Shall we take a 10-minute break? You can reply in the chat. If you want a 10 minutes break, we can take a 10-minute break. It's going to be a long lecture because I have to cover everything. Yes, no, yes, no. How many yes, how many no? Based on the yes and no, I'll be just deciding. 10 minutes break? No, yes. Most people are into the no spectrum. Okay. No problem. I'm ready to continue. Maybe I'll give you 2 to 3 minutes break. Okay. Let's come to a conclusion. I'll give you 5 minutes break. Go ahead, grab some tea or coffee and come. Okay. 5 minutes break. Slides will be there. You have to approach my moderators, doctor, because I'm not dealing with the slides. I just give it to them. They will be dealing with that. Contact the management. They will help you out. We'll take a 5 minutes break. Okay. Because it's going to take another 2.5 hours. We'll take a 5 minutes break. Okay. Stretch out and get some coffee or tea for you, whichever you want to keep yourself awake, and come back. Talking about entire endocrinology, I'll tell you, see, what we are covering here is the essential parts. Okay. I joined a course for SE examination. Okay. Specialty certificate examination is in endocrinology because I like endocrine. I've been very fascinated about the subject. For that SE examination, we have 600 hours of lecture for endocrine alone. If you want to actually cover entire endocrinology, it will take that much of time, because for acromegaly, if they take a condition, they are teaching for 3 hours acromegaly alone, and treatment, pros, cons. For diabetes mellitus alone, they have nearly 200-250 hours of lecture. If you are going to teach that much, most of the people here will go away. So we are just covering just what is needed for you for your part 1 examination and part 2 examination together. The main images, case history, the basics, the core concepts, how the questions will be asked. The next part of this, okay, for the next part of this, I am just talking about specialty certificate examination. That is not for MRCP, okay. This is not for MRCP. For MRCP, we have, for each subject, we have around 3 to 3.5 hours of lecture, except clinical pharmacology. Clinical pharmacology, we have nearly 9 to 12 hours, okay. Again, I'm repeating, don't get confused with what is written on the slide. Okay, I'm repeating again. For MRCP, especially MRCP-1, we have 3 to 3.5 hours lecture for each and every subject. We are covering core concepts, basics, and all the important topics. Definitely much better than whatever notes you're having in your hand. I can bet on it. We are covering those things, and with some updated guidelines, with whatever we can in the 3 to 3.5 hours. I'm afraid to say maybe 1 or 2 topics we may miss. That's the reason we wanted to sit and work MCQs with you, all the MCQs in past test and past medicine. That's why I propose them so much. I don't know whether management is going to do or not, but this is the best thing we can do for you. Except for clinical pharmacology. Clinical pharmacology, we have 9 to 10 hours plus lecture we have, because it happened over a span of 4 days. We had a pharmacology carnival, a lot of people enrolled, and they found it really beneficial. So that is different. For other subjects, 3 to 3.5 hours. Okay, I think that should be good enough. Now comes a 34-year-old woman presents with complaints of weight gain, irregular menses. For the last several years, she has gained 20 kg over the past 3 years and feels the most of the weight gain is in her abdomen and as well as the face. She notes some bruising without significant trauma, difficulty rising from a chair, and proximal muscle wasting. She was diagnosed with type 2 diabetes and hypertension. What is the diagnosis here? A lady, weight gain, irregular menses. Listen, this is not PCOD. A lady, weight gain, irregular menses, proximal muscle wasting, and proximal muscle weakness. PCOS will not have proximal muscle wasting and proximal muscle weakness. Very, very careful. This is nothing other than Cushing. See this lady, for example. This is one of a patient. I want you to look at the patient.
You're wanting to know about the Cushing's buffalo hump. You can see right here that is.
See, that is the buffalo hump. You can see that.
That is a sign of Cushing's.
And you can also notice some acanthosis nigricans here, thickened skin fold over there. That's an acanthosis nigricans you can see here. Okay, this is a classical Cushing's patient. Okay?
You're wanting.
Now, all of you should be very, very clear about 2 things. What is a Cushing's disease and what is a Cushing syndrome? Both terms are interchangeable, and a lot of people gets confused between this thing. Remember, Cushing's disease is a very serious condition. Cushing syndrome is not. For example, if I'm going to put some patient on steroids, he may develop all the symptoms. That's not a Cushing's disease. It could be a Cushing syndrome, because the moment I'm going to stop, taper out, and withdraw the patient from steroids, the patient will become perfectly all right. That's a Cushing syndrome. Cushing's disease is not that. That has to do with your pituitary tumor. Okay, that has to do with the pituitary tumor. Cushing syndrome is due to excessive secretion of cortisol due to any source. Just make sure disease is central head pituitary tumor. It is a serious condition. Syndrome is not. Just at least know this point. Okay, then I'll take you to each and everything about Cushing's disease. So now comes to the investigation. Okay, this can be, don't know how to just take away this zoom bar. This is disturbing. Investigations for Cushing syndrome. Okay, there are two. First, step by step we will go. Okay, don't get confused, because this can be absolutely confusing. Investigation of Cushing syndrome, so many things they will give you to confuse you, to just throw you out. Don't worry, we are going to work it out. First, confirm it is a Cushing's. Okay, always rule out the cause. Always check any iatrogenic or exogenous administration of any form of steroids. Okay, iatrogenic or exogenous administration of any form of steroids has to be ruled out. Ask the patient, are you taking any steroids? Have you been put on any kind of steroids? First, rule it out. First thing, okay? That will rule out Cushing syndrome. Then 3 tests is recommended by Williams Endocrinology and UK Endocrine Society. Late night salivary cortisol, urinary free cortisol, or a low dose dexamethasone suppression test. Okay, I'll now tell you how to approach this. Okay, first you are ruling it out, then one of the 3 tests. All right, are you all clear? First, to rule out exogenous or iatrogenic usage. Then one of the 3 tests. Any one of the 3 tests. Any one of the 3 tests. Now I will tell you how to approach. This one table is more than enough. You don't need to get confused learning this and that. Okay, this one table is more than enough, because up to date gives in a different way. Okay, want me to repeat the previous slide? Just 3 things, doctor. A patient, you are suspecting a Cushing's disease or Cushing syndrome. He or she is sitting right in front of you. First thing, ask the patient, are you taking any steroids? Can I have your medical records? Have you been put on any steroids? If the patient says yes, stop the steroids. Taper it out. Okay, problem solved. If the patient says no, no doctor, I never took any steroids in my life, then 3 tests, any one of the 3 tests. Late night salivary cortisol, urinary free cortisol, or a low dose dexamethasone suppression test. Okay, any one of the 3 tests you have to do. Okay, if these 3 tests are abnormal, or any one of the tests are abnormal, okay, now proceed to this. I will explain you how and why it is abnormal. I'll tell you some physiology as well to make you understand. Getting it? Okay, so no one should get confused. I don't mind sitting and here teaching for you even next to 7 hours also. I want all of you to understand before leaving the lecture. No one should go confused. First thing, ONDST or salivary cortisol, any of the 3 tests. Any ONDST is overnight dexamethasone suppression test. Okay, you are taking. You have to take typically 2 samples, they recommend me. Okay. After giving the dexamethasone, if the plasma ACTH, again you have to measure 2 times. This is also given 2 times. In UK, typically we give 2, but I don't know here, and I don't know about the countries you are from, how many times you are taking, because you all are from different countries. Just know the basics. If the tests are inappropriate, okay, you are taking the plasma ACTH level. If the ACTH level is less, okay, it is mostly an adrenal cause. Why and how, I will explain you. Okay, this is your brain. Here is your pituitary gland. Okay, never mind my diagrams, they are just representational purpose only. Okay, I know it is looking like some sort of ice cream cone. This is your kidneys, and above this is your adrenal gland. This is your pituitary. Okay, and you are giving an injection of dexamethasone. Okay, normally adrenal gland will secrete cortisol. Okay, you give dexamethasone. Okay, you give dexamethasone, it should suppress cortisol secretion. Okay, once cortisol secretion is going to be suppressed, then your ACTH level should fall. ACTH level will fall to the normal range. But if the ACTH level is less than 10 after giving dexamethasone, okay, ACTH level is less than 10 after giving dexamethasone, then what it means, okay, Remember very clearly, if the ACTH level is so low, pituitary secretes ACTH. Here comes your cortisol. If the ACTH is low, even after you are giving this dexamethasone, then what does that means? Then there is something else that is going and suppressing this ACTH. Okay, something else is going excessively and suppressing in spite of giving your dexamethasone, because dexamethasone should normally suppress the cortisol level. So cortisol, what cortisol does? Cortisol, when it increases, it goes and it decreases ACTH. That is called negative feedback mechanism. But in still after giving dexamethasone, cortisol is too much and going and suppressing your ACTH, then it means cortisol is secreted excess and in an abnormal fashion. Okay, then it can be a disease that is in the adrenal. So you have to take adrenal CT or MRI. Okay, be very clear. You are suspecting a patient with Cushing syndrome. You are asking questions. No steroid use. You are taking 3 tests. If 3 test is abnormal, you are going to check plasma ACTH. If the ACTH is too low, what is the answer? Then there is something going on with the adrenal gland. It is secreting too much cortisol and it is going and suppressing the ACTH to the ground level. So you have to take the CT or MRI of the adrenal. Okay, adrenal glands. If the adrenal glands are normal, it can be due to any exogenous glucocorticoids. Maybe somebody is taking steroids to build a muscle or something. If it has a unilateral mass, okay, unilateral mass, it can be due to adrenal adenoma or adrenal carcinoma. If there is a bilateral adrenal enlargement, it can be due to a lot of causes, but I want you to remember one particular cause, that is McCune-Albright syndrome. All of you are clear with this? Anybody has any doubt? I hope nobody should have any doubt, because I told you the very basic things here. Okay, very basic thing. Okay, now if the ACTH is more, okay, ACTH is more, all you have to do is take an image of pituitary. What happens? Why ACTH is low? You are giving DEXA, okay, the cortisol is fine, but ACTH is too much. ACTH is too much secreting. It can be due to 2 things. Okay, please repeat, sir. I am confused. Okay, for you, no problem. I am ready to repeat. First, make sure very clear. You are asking the patient, you are taking steroid or not. Patient is not taking steroid. Then you taking 3 tests, either overnight dexamethasone or low dose dexamethasone or a late night salivary cortisol or urinary free cortisol level. If it is abnormal, then you are taking ACTH level. If ACTH level is too low, it can be due to only one cause, that is the cortisol, which is produced by the adrenal gland on top of your kidneys, is going secreting so much and suppressing the ACTH. Then you have to check which part. You have to check the adrenal gland, right? Okay, how do you check the adrenal gland? By taking a CT scan. If you find normal adrenal gland in CT scan, then you have to think whether the patient is illegally taking some steroids without the doctor's knowledge. Got it? All the 3 screening tests are good, doctor. It is followed by different test. Okay. For me, if you ask me, I do low dose dexamethasone suppression test. The same answer may not come from another physician, because he will be in a different trust. He would have been doing something else. Okay. And so you are taking the CT scan and you are checking the CT scan and checking the adrenal. If the adrenal glands are normal, then the patient is exogenously taking steroid. If you are finding adrenal glands, okay, you have 2 adrenal glands. 2 adrenal glands are there, right? Your left kidney and right kidneys. If there is only one adrenal gland that's showing any mass, then it can be due to adrenal carcinoma or adrenal adenoma. If both the adrenal glands are enlarged and your ACTH is terribly low, then it is due to one syndrome I told, that is McCune-Albright syndrome. Okay, now we are clear. Doctor who asked, Dr. Rohan Rasaruba. I hope you are clear, right? And hypercortisolism, that is negative feedback, doctor. Negative feedback. If it is excess cortisol, always going to decrease the ACTH. Mostly. And which of the best test among the 3? For me, it is low dose DST. They won't ask you which is the best test. They will give you any one of the thing. Late night salivary cortisol is elevated, or they will give UFC is elevated, or they will give one of the three. But they will ask you what you will do next. That is ACTH level measurement. Then they will ask you what happens. What will you do if the ACTH is low? What will you do if the ACTH is high? That's what you need to know. All right. Now we saw what happens when ACTH is low. Now we come to another scenario. Okay. Now all of you are clear. If ACTH is going to be high, what we are going to do? Okay. I'll erase everything. Assuming you learned. If ACTH level is high, simple thing. ACTH can be secreted by where? McCune-Albright syndrome, when both the adrenal glands are enlarged. About McCune-Albright syndrome, we will come to that in neurology teaching. Okay. Or in dermatology, I will teach you. Okay, ACTH is secreted by two sources. It can be either coming from your pituitary, or it can be coming from some tumors, of islet cells, pancreatic tumors. Okay, so if ACTH is high, always remember, check the pituitary. It could be Cushing's disease. If you are checking a pituitary, you're seeing an MRI, pituitary is normal, then you should be thinking, where ACTH is coming. See for any ectopic ACTH. That's all. That's all you need to know. Okay, that's all you need to know. If you know this much, that's more than enough for Cushing's. They are not going to ask you anything. Okay, they are not going to ask you anything. They may ask you one thing. I will tell you. If in MRI pituitary, MRI of a pituitary, there is no mass, and you are doing a PET scan. Typically, we use PET scan to see any metastatic tumor or any ectopic ACTH secretion. That is also normal. What you will do? You have to do something called inferior petrosal sinus sampling. That's one thing you remember. All right. That one thing you remember, nothing else. This is about Cushing syndrome. I hope all of you are clear. There is a difference between ectopic and pituitary tumor. If they ask you, how do you differentiate? Or if they give any values, okay. Typically for MRCP-1 level, they will definitely give you a MRI picture or MRI they will give there is a tumor in pituitary, or if there is no tumor, they will expect IPSS value, inferior petrosal sinus sampling levels. Okay. In spite of all that, sorry, I don't know how to push it away from the screen. Yeah. If they are not given any kind of value, God forbid they given some biochemical value, you should be able to differentiate between a ACTH secreting pituitary tumor or if it is ectopic. That you are confused, either it is coming from your brain or is it coming from some gland like your pancreas. So how to differentiate? Typically, ACTH secreting pituitary tumor is more common in females than males. In case of ectopic secretion, if there is ectopic secretion, then you have to go for in case of ectopic, then males are more common than female affected. And ACTH secreting pituitary tumor, that is your Cushing's disease, is slow onset, whereas an ectopic paraneoplastic is rapid onset, and there will be pigmentation and myopathy can be very severe. This is one of the point of differentiation. And another thing, serum potassium, hypokalemia is more pronounced in ectopic ACTH. Okay. Then one more thing that you should know is high dose dexamethasone test will suppress cortisol in case of ACTH secreting pituitary tumor. It cannot play around with ectopic secretion. 3. And another important thing is, for example, someone asks if MRI does not detect, you have to do is IPPS, inferior petrosal sinus sampling. If the value is more than 2, then it is an ACTH secreting pituitary tumor. You will still go and resect the tumor based on a neurosurgical advice. If they didn't give you the proper MRI picture, then you can still differentiate based on the following facts. I hope all of you got it, right? Cushing's treatment for ACTH dependent disease, straight away nothing other than transsphenoidal resection. Before resection, typically a somatostatin analog or a dopamine agonist can be tried. But if they ask you what is the most appropriate method or mode, transsphenoidal resection, you resect it. And post-resection, hormone replacement. For ectopic ACTH secretion, okay, ablation of the tumor is the standard procedure. If it is coming from pancreas, you ablate the tumor. If it is coming from any other organ, try to remove the tumor off. All right. This is something called as your Cushing's reflex. This is again, I'm sorry, 1 minute. Yeah. This is again another guy with Cushing's. Okay. I'll explain this. There is something is wrong with the video. I'll just show the videos again and explain you. Now we will quickly go to the Graves' disease. Now we have completed pituitary gland. Almost most of the things which they will ask from the pituitary gland, we have completed. Now we have come to the thyroid gland. In thyroid gland, the very first disease you should be knowing is your Graves' disease. It's mainly due to thyroid stimulating immunoglobulins. Okay, mainly due to thyroid stimulating immunoglobulins. This has been asked. Presence in the lymphocytes of the thyroid gland. Okay, because they had asked which of the following cells plays a major role in pathogenesis of Graves' disease. They have given eosinophils, neutrophils, macrophages, a lot of things. And the lymphocytes is the answer they expected. Here, antibodies are directed against TSH receptors, TRAB antibodies. Second thing. Okay. Third thing. Also, TPO and TG antibodies can be seen, not just TRAB antibodies. TPO and TG antibodies can be also seen in case of a Graves' disease. In elderly patient, the features of thyrotoxicosis can be subtle. You won't typically find all the features of thyrotoxicosis, like what? Hair fall, anxiety, all your thyroid eye signs, including, your proptosis, your lid lag, okay, your ophthalmoplegia, corneal ulceration, whatever it is, all those things, your tremors, your tachycardia may go for atrial fibrillation, all these things, your diarrhea, all these things may not be seen in elderly patients. Elderly patients, many times the symptoms are completely masked. Okay, they may present only with fatigue and weight loss. This is known as apathetic thyrotoxicosis. Just to remember the term, they may ask you. Apathetic thyrotoxicosis is in elderly patients, you won't find any of the Graves' disease symptoms. It's called apathetic thyrotoxicosis. And this has been asked, most common cardiac manifestation is sinus tachycardia. Remember, most common cardiac manifestations of Graves' disease is nothing other than your sinus tachycardia. All right. This I'm not going to go into detail. I'm going to go into detail about something very important, that is radioiodine therapy, which is very, very important for part 1, part 2, and PACES, all 3 candidates. First, it is contraindicated in pregnancy and breastfeeding. First point. Second point, pre-treatment with anti-thyroid drugs should be done to avoid thyrotoxic crisis. Okay. Pre-treatment with anti-thyroid drugs is important. Okay. In elderly patient, if they are giving you a scenario, okay, in elderly patient, if they're given a scenario, in old patients or in elderly patients, if they are given in any scenario, you have to add beta blockers along with anti-thyroid drugs before going for radioiodine therapy. For example, they will ask you an MCQ. A 52-year-old female is scheduled for radioiodine therapy. What are the drugs you can give? They may mention some carbimazole, methimazole, whatever anti-thyroid drugs is available. And they may ask you also an option, carbimazole with methimazole with beta blockers. You have to tick it because beta blockers is added in elderly females. Okay. 2 to 3 days before you don't give carbimazole. Patient can conceive safely after 6 months. This every point is from NICE guidelines. Okay. Patient can conceive safely after 6 months. This can be asked in MCQ also. This came in PACES scenario where they have to counsel the patient when I can safely conceive after getting a radioiodine treatment. And radioiodine treatment should be avoided in active thyroid eye disease. Okay. Also, it is contraindicated in case of smokers. They should stop smoking before starting the treatment because smoking can worsen the thyroid eye disease. And patient needs to avoid prolonged contact for 7 to 8 days with pregnant women and children. These are the points about radioiodine, very, very important. Pregnancy, breastfeeding is contraindicated. Avoid going near pregnant women and children. You should give antithyroid drugs before it. In case of elderly patient, what you will give? You will give antithyroid drugs plus beta blockers. Okay. These are the points you should know. And someone asked something, sir, mostly we study endo, every disease has associated with other disorder. Yes, doctor, that is called autoimmune polyendocrine syndrome and men. These are the two associated diseases they will ask. We have slides for that. We will learn that. Don't worry. Then comes to thyroid storm. This is again some of the scenarios that's been asked. In case of patient with stroke, any illness or trauma, as well as diabetic ketoacidosis or any surgery, there will be some hyper release of thyroid hormone and patient present with a dramatic fashion. Okay, could be due to cardiac arrhythmia, hyperthermia, everything will be there. That is called a thyroid storm. I hope all of you know that. But they asked, what is the reason for mortality in a case of a thyroid storm? The most common reason, number one, is cardiac arrhythmia. Number two is hyperthermia. These are the things that can actually kill the patients. Because from sinus tachycardia, it can go to atrial fibrillation. From atrial fibrillation, it can go to ventricular fibrillation, and it can go for arrest in case of a thyroid storm. Next is hyperthermia. These are the two causes for death in a patient or a mortality in a patient with thyroid storm. So in a case of thyroid storm, how you are going to treat the patient? Everything is important here. Again, because they had asked frequently. First thing, you have to give a large dose of propyl thiouracil. Okay. First, remember, large dose of propyl thiouracil. Okay. Second, after giving propyl thiouracil, you have to give stable iodide. Okay. Stable iodide. Because iodine again inhibits the thyroid hormone synthesis via Wolff-Chaikoff effect. This is physiology, you also know. Third, along with that, you have to give propranolol because you don't want tachycardia to go into fibrillation to arrest. So you have to give propranolol. Don't need to worry about doses. If you are interested, if you are a clinician actually practicing in clinic and want to learn more of these things, you can remember the dosage. The best way to how dosage will come into your head is by prescribing and working in the clinics and prescribing frequently and doing the case sheets. You will easily get to know that. Okay. Wolff-Chaikoff effect is simple, doctor. Okay. You give excess iodide, it is going to block the thyroid hormone synthesis. That's it. That's called a Wolff-Chaikoff effect. And fourth is additional therapeutic measures you have to give here. You can also give glucocorticoids. Okay. And antibiotics. In most of these things, you have to give an antibiotic coverage if the infection is present. And you can give cholestyramine to sequester thyroid hormones and cooling, oxygen, and IV fluids. Why cooling is important? I told you the second most important cause of death in thyroid storm is what? Hyperthermia. So cooling and oxygen is important. And IV fluids also very important. So fourth step, seeing a patient with thyroid storm, admit, secure IV line, give large dose of propyl thiouracil. Then also give iodide hormone. Then immediately also you have to give in another line propranolol to reduce the tachycardia. Then you can give glucocorticoids, antibiotics, cooling, oxygen, IV fluids. All right. And cholestyramine is another drug that can, is a bile acid binding thing that will bind to the thyroid hormones that is in the circulation and sequester them. All right. This is the measurement and the treatment for thyroid storm. Now comes another important topic in thyroid is subacute thyroiditis, otherwise known as decoherence thyroiditis. Recently, post SARS-CoV-2, it is noted to increase tremendously. It is increased. A lot of cases we are getting, and peak incidence typically 30 to 50 years. This is one of the symptoms of long COVID. Gland shows a patchy inflammatory infiltrates with giant cells. This decoherence thyroiditis has two phases. Okay. All right. The initial phase is nothing other than the follicular destruction phase. Okay. Follicular destruction phase followed by increased thyroglobulin T3 and T4. First is the follicular destruction phase. Okay. There will be increased TG, T3 and T4. The next step is a total destructive phase. In the destructive phase, what happens is radioiodine uptake is totally reduced. That is a time if you do a radioiodine uptake scan, the uptake will be reduced. And low unbound T4 and moderately increased TSH is seen. Third is a recovery phase where everything will come back to normal. Once again, I am repeating, DQR1, thyroiditis, 3 phases it has. First is a follicular phase. Initial phase, there will be increased TG, T3 and T4. Number 1. The second phase, the radioiodine uptake will be decreased. The third phase, unbound T4 and TSH will be moderately low, unbound T4 and moderately increased and moderately increased TSH is seen. This is how subacute thyroiditis progress in 3 different phases. They will give a history of a 30 to 50-year-old male with any of these findings, and they will typically give you radioiodine uptake is reduced. Then you suspect subacute thyroiditis. Patient typically present with a painfully enlarged thyroid, okay, with some fever. This is one of the clues. Painfully enlarged thyroid with fever. Pain, it's common to spread to jaw and anything. You don't need to do anything. Just give him the NSAIDs. That's more than enough. Treatment is NSAIDs. Don't go around put radioiodine or thyroid hormones or any iodides, glucocorticoids and all. That is not needed in DQR1s. They will typically give a presentation of painfully enlarged thyroid in a patient with 30 to 50 years old with fever and reduced thyroid iodine uptake. The common thing is DQR1. Typically treat with NSAIDs. Rare cases, you may need steroids. Like the other doctor asked, do we give steroids in every patient? In thyroid storm, I have seen steroids as one of the prescription in our trust where I worked. Now I'm no longer there. Where I worked, I have seen people prescribing. So, okay, that is a drug that has to be added on in the later day. Definitely that is in the prescription. Then another syndrome I want to tell we have added now is Pendred syndrome. What is a Pendred syndrome? Typically, they will give some of the history, some thyroid disorder, typically thyroid hypothyroidism with bilateral sensory neural deafness. These are the 2 classical things they will give you in the history or in your MCQ stem. If you find these things, then it is going to be nothing other than your Pendred syndrome. It is an autosomal recessive genetic disorder that is characterized by bilateral sensory neural deafness. Okay. Remember this because they may ask you in basic sciences, Pendred syndrome is autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive. They can confuse you. So read very clearly. It's an autosomal recessive disorder. There may be small goiter with hypothyroidism and sensory neural deafness. At least know these 4 points. Done. You'll be able to diagnose. Okay. There is defect in the organification of iodine. Even if you don't remember that, it's fine. But I want you to remember it is autosomal recessive. Sensory neural deafness is there. Okay. There is hypothyroidism and a goiter is there. At least these 3-4 points you remember. Okay. Chromosome 7 is affected. Perchlorate challenge test is done for this. This they may not ask you. MRI will typically show 1.5 turns in cochlea instead of 2.5 turns of cochlea. I never seen cochlear MRI and all. Cochlea typically has 2 turns. Here there will be the 2 turns won't be there in cochlea. It will be incomplete turns of cochlea they call. This is one of the characteristic MRI findings in case of a Pendred syndrome. Especially I'm telling this point for anyone here who is going to appear for part 2 MRCP examination. They may try to put this. Okay. See how the complete turn of the cochlea is not there. Here also you can find. Okay. This is a Pendred syndrome. Now, another thing I want to tell you here. They may give a history of thyrotoxicosis with low or absent uptake. Okay. We have seen DQR1. If there is a features of thyrotoxicosis, highly increased T3, T4 is there. Okay. T3, T4 is tremendously high. But low or absent intake. What can happen? They may give a scenario. This is happening in case of a pharmacist or a medical student or a nurse. Okay. Typically, that's why I put this picture. A pharmacist or a nurse or a medical student or even doctors can also do that. So what could be the cause of a thyrotoxicosis with the low or absent in uptake? The very first cause you always you should think of is thyrotoxicosis factitia. externally this patient is swallowing up levothyroxine or L-throxine, whatever brand name you are getting in your country. If the person is externally taking this in excess, that can cause this thyrotoxicosis factitia. That could be one of the causes. Another cause is increased iodine intake. If the patient is purposefully taking excess amount of iodine, it can cause that. Number 3, another thing that can happen in this case is struma ovary. That is a part of ovarian tissue, that can secrete your thyroid. Increasingly, it can secrete your thyroid gland. This is one of the possibilities. So thyrotoxicosis with lower absent uptake can be due to thyrotoxicosis factitia, increased iodine intake, or struma ovary. Don't forget this. Okay. Then another thing in thyroid, which I want to be covered, is sick euthyroid syndrome. Many will get confused. What is the sick euthyroid syndrome? For example, anyone with an acute severe illness, for example, somebody is getting a COVID, he is admitted maybe in the hospital for 8 days, 10 days, any number of days. This severe illness can trigger IL-6. IL-6 is what? Interleukin 6. This interleukin 6 will play up with your TSH level. Okay, this can alter the thyroid hormone levels. Okay, once again, I'm repeating you, somebody is having an acute severe illness like a COVID, he is admitted for a couple of days, and as a result of the prolonged admission, it can result in increase in amount of IL-6, that is interleukin 6. This interleukin 6 in turn can lead to alteration in the TSH level. That is called a sick euthyroid syndrome. There are 2 main patterns of sick euthyroid syndrome are seen. The most common type of pattern is non-thyroid illness. Typically, they will give a value of decreased unbound T3 with normal T4 and TSH. T4 and TSH will be normal, but surprisingly, T3 will be little low. They will give in the history the patient has been admitted in the hospital for a pneumonia or for COVID or for DKA, pancreatitis, whatever for quite a long time. Always think it could be a sick euthyroid syndrome. Clear? You know why it is occurring? It's due to IL-6. This is pattern number 1. Second type of pattern is called low T4 syndrome. Here what will happen is there will be decreased T4 and slightly decreased T3 with normal TSH. What should happen if T3 and T4 are decreased? TSH should increase, right? But it won't happen here. If you find this pattern in a patient who is admitted in the hospital or hospitalized, it is called as your sick euthyroid syndrome. Got it? This is another important thing. Okay, sorry, that slide is repeated. So this is a exercise for you. Can you identify what drug is this? Not just identification, you should tell me. Low T3 syndrome, T4 will be high. It can be high, it can be normal to doctor. Either way, it's amiodarone. Why it is amiodarone? Reasoning? This is the guy who invented amiodarone. This is amiodarone induced pulmonary fibrosis. You can see fibrotic changes. This is the chemical structure of the amiodarone. Amiodarone is a potassium channel class 3 antiarrhythmic. Okay. All right. This is amiodarone. Amiodarone can induce thyroiditis. It's called AIT, amiodarone-induced thyroiditis. In this amiodarone-induced thyroiditis, I want you to be very focused on 2 types of amiodarone-induced thyroiditis. There are 2 types, AAT1 and AAT2. AAT1 is typically associated with some underlying thyroid abnormality. Okay. AAT1 is due to excessive iodine exposure lead to increased thyroid hormone synthesis. That's Jode based. Just remember that. AAT2, always remember one thing. The word which I'm going to write here is the word you are going to remember, destructive. It means it's a type of thyroiditis that will destroy the thyroid gland. Once the thyroid gland is destroyed, you are going to put a USG probe into the thyroid gland. It will show decreased vascularity. Okay, it will show decreased vascularity. All right. Once again, I'm making it very clear. AAT1 always occurs with an underlying thyroid abnormality. Number 2, it's due to jode-based phenomenon. That is, you give excess thyroid hormone, it will cause increased thyroid. Excess iodine, it will cause increased secretion of the thyroid gland. AAT2, on the other hand, it's due to destruction, autoimmune lysosomal activation activation leading to destruction. As a result of that, vascularity will be decreased. Typically, they may not directly mention, they may tell a patient taking amiodarone for quite a long time for some atrial fibrillation or anything, or some heart disorder. That patient USG of the thyroid shows decreased vascularity. What could be the cause? AAT2. AAT1, you can give antithyroid drugs, AAT2, you can give steroids. Steroids are the only option for AAT2. Steroids, destructive, decreased vascularity. Remember that? That's more than enough. Okay. Evaluation of hypothyroidism, I'm not going. This is a radio uptake scan. If there is a cold nodule, it is little dangerous. It can be malignancy. Hot nodule is good. It's actively functioning gland. This is a Graves' disease, uniformly enlarged. And autonomous nodule, just one particular spot in the thyroid gland. If it is enhanced, it is called autonomous thyroid nodule. And hot and cold nodules combined together, it's a toxic multinodular goiter. If you find some dispersed uptake and decreased uptake, it's a thyroiditis. Okay. Now we go to another important section in the thyroid glands, that is your thyroid malignancies. Okay. Thyroid malignancies. Okay. There are a lot of risk factors for thyroid malignancies. Okay. Lot of risk factors for thyroid malignancies. We can pick it up. But I want to tell certain very, very important thing which you need to know. This is called Bethesda classification. This will be further dealt in oncology section. Okay. This Bethesda, what are the type of things that will be dealt in oncology section. I am going to give you my medicine point of view about certain things which you need to know. First type of carcinoma I want all of you to be aware is papillary thyroid carcinoma. Whatever I'm going to tell you are the bullet points you need to know. Rest, you don't need to worry about that. Most common type of thyroid carcinoma. Okay, only once I'm going to repeat because we are having tremendous amount of things to learn more tonight, because we have diabetes mellitus which we haven't touched yet. Am I right? Diabetes itself has a lot of things to be learned. A lot of things we need to learn in diabetes. So I'm going to be just repeating only once. Be very, very attentive. Next thing I want you all to know is, in this particular carcinoma, it has a large clear nuclei. The nuclei will be large and clear, some chromatin with a nucleolar groove. This is called as orphan Annie nucleus. I will show you. Okay, this is called orphan Annie nucleus. I'll show you what it is. The classical and follicular variant, there are a lot of variants, classical and follicular variant, which shows a more indolent course, where tall columnar hobnail variants are aggressive. This is pathology. Even if you don't know, it's fine. It's multifocal and it invades locally and it can spread via lymphatics and blood to lungs and bones. This is important. Okay, this is important. Typically, in early stages, the prognosis is better because you are going to see, find it early, and as well as a result of finding it early, you are going to treat it early. So if you find it early and treat it early, the prognosis is going to be absolutely better. Later stage carries worst prognosis. This is common for every cancer. Okay. Tumors of more than 4 centimeters will need near total thyroidectomy. This they may not ask you, but still better to know. But what they had asked frequently in MRCP examination is the point which I'm going to underline right now. That is, thyroglobulin TG should be monitored. This thyroglobulin is the most sensitive marker for recurrence. They had asked in oncology and endocrinology, which of the following is the most sensitive marker for recurrence of the papillary thyroid carcinoma? What you will answer? Thyroglobulin, thyroglobulin, thyroglobulin. I'm repeating 3 times. It's the most common carcinoma of thyroid. Okay. This is a papillary thyroid carcinoma. It's a macroscopic appearance you are seeing in picture A. In picture B, there is a well-formed papillae. You can see here, well-formed papillae in the thyroid gland. Picture C is your orphan nucleus. I'll enlarge and draw one orphan nucleus here. That is a cartoon character called orphan Annie. And D, this is again fine needle aspiration cytology of papillary thyroid carcinoma. There are intracellular inclusions are here. Okay, this is how it looks. And TSH suppression in thyroid cancer, they had asked in MCQ. Some patient was having thyroid cancer. What is the limit you will maintain for TSH? Remember this 0.5 to 2. You have to remember this? Yes, you have to. Because they had asked, so you have to remember this. Okay, don't ask me whether do I have to remember. Yes, you have to. Okay, rest of the thing you know or don't know doesn't matter. In a metastatic disease, they had asked once, TSH should be less than 0.1. At least these two things you remember. Okay, two things you remember. They had asked what is the level of TSH you should keep in case of a thyroid cancer. Okay, if you see the differences between all this thing, papillary thyroid carcinoma is the most common, 70%. Typically occurs in young people. Most common metastatic site is lung. Follicular is 20%, more in females. Again, the same thing. Anaplastic is aggressive and it's locally invasive, poorest prognosis. Okay, it's the worst thyroid carcinoma is anaplastic. Medullary, we will deal extensively. Wait, okay. Now we are coming to the second type of thyroid carcinoma. Again, I'm going to repeat only once. Pay attention. It's called follicular thyroid carcinoma. It is more common in iodine deficient region. Iodine, sorry about the spelling mistake. Iodine deficient region. Okay, they may ask you an MCQ, which of the following carcinoma of thyroid is more common in iodine deficient area? Follicular thyroid carcinoma. The characteristic feature of the follicular thyroid carcinoma is a capsular or a vascular invasion, which is not seen in any other thyroid carcinoma. Okay, be very clear. And here, lobectomy is typically enough for follicular carcinoma with capsular invasion. They may not ask you about that, but still it's my duty to tell you that. Okay, metastasis can be seen in thing. If it is going for a metastasis, survival rate is dismal. That is a common dictum for any carcinoma. Poor prognostic factors of follicular thyroid carcinoma has been asked in MRCP MCQs. What are they? Age more than 55, tumor more than 4 centimeter, and angioinvasive tumor. Just remember, higher the age group, bigger the tumor size, and higher the mets. If it is angioinvasive, means it is spread via the blood channels. If you find all these three things, the prognosis is going to be very poor. Okay, this is a follicular thyroid carcinoma. Okay, it's a gross picture. This is the picture, histopathological picture. Okay, now comes the interesting thing, the medullary thyroid carcinoma. Why it is interesting? It is very important in one of the most common topic in endocrinology, that is a Men's syndrome. Okay, we will see about Men's syndrome separately today. Don't worry, they form up to 5% of thyroid carcinoma. 5% of the thyroid carcinoma is a medullary thyroid carcinoma. They are associated with MEN2A and as well as MEN2B. Among that, MEN2B is the most aggressive variant. Also remember, this can occur without Men's syndrome also. Okay, can be associated with Men's syndrome with or without it as well. Okay, there won't be radioiodine uptake. The thing that is asked along with the Men's syndrome is RET oncogene. This has been asked as MCQ, remember clearly. Which oncogene is responsible for medullary thyroid carcinoma? RET oncogene. Okay, and what is the marker for tumor recurrence is calcitonin. This is very, very, very important. Other thing, palliative radiotherapy, chemotherapy, don't remember, it's fine. But whatever I underlined, very important. It is associated with MEN2A and 2B. 2B is more aggressive. It can be sporadic, means it can occur without Men's syndrome also. And what is the tumor marker for recurrence? Calcitonin. What oncogene is associated with it? RET oncogene. This is MTC. This is the histology. This is the gross picture of the tumor. This is an electromicrograph for medullary thyroid carcinoma. Okay, this storage granules has calcitonin. Anaplastic thyroid carcinoma. This is a most aggressive variant. Most patient from the time of diagnosis, It's very unlikely they are to survive beyond 6 months. Okay. External beam radiation can be tried here. Then comes thyroid lymphoma. This is very, very important. Especially the very first point is very important. Okay. Most commonly arises in the background of Hashimoto's thyroiditis. Okay. Which of the following malignancy can be associated with Hashimoto thyroiditis? Which of the following malignancy can be arising from a Hashimoto thyroiditis? Always remember thyroid lymphoma. No doubt. Okay. It's a rapidly enlarging mass, should be suspected of thyroid lymphoma. And among this, diffuse large B-cell lymphoma is the most common. Treatment, if they ask, external beam radiation. Okay, this is about thyroid lymphoma. Next, we will go to another case. Okay, we'll do some more slides and we can take a break. At a routine examination, 55-year-old woman is discovered to have hypercalcemia. Follow-up of laboratory tests shows synchronously elevated serum calcium and intact parathyroid hormone, a low phosphorus and mildly elevated alkaline phosphatase. 25-hydroxyvitamin D is low normal. Past medical history significant of hypertension, coronary artery disease, review of symptoms noticed, fatigue, feeling achy, vague depression, mental fatigue. All right, all features of hypercalcemia. There is a history of nephrolithiasis. Okay, what could be the diagnosis here? A hypercalcemia, low vitamin D, elevated alkaline phosphatase. What are the possibilities? Come on, be interactive. We have very little time. Okay, we have very little time. We don't have a long time. I have to cover a lot of things for you. Excellent. Yes. Okay. Excellent. What is the action of PTH on calcium? This slide is important. I'll just read through you. Then you guys please note it down and know that, because this is very important for, again, your basic sciences questions. How PTH acts on calcium? It increases osteoclastic resorption of bone. That's the fast response. Also, it increases intestinal absorption of calcium. Once PTH comes, the PTH acts on the bones first. Sorry, how to draw a bone. Yeah. This bone, and then it also acts on your stomach and your intestines. Two response. This is the fast response. This is the slow response. Remember, the fast response, it goes and causes resorption of calcium from the bone. Resorption of bone causing osteoclast resorbs the bone and thereby conserving calcium. Second, it acts on the intestine by absorbing calcium. Third, it increases the synthesis of dihydroxyvitamin D. Then it increases renal tubular reabsorption. Also, it also acts on the renal system. It reabsorbs the calcium from there. And also it excretes the phosphate. All right. These 5 points, remember. And this is a question that has been asked. Guidelines for surgery in asymptomatic primary hyperthyroidism. That's why I got this table straight from Harrison's, because questions has been asked in this. NICE doesn't have a great guidelines on this particular part, so we need to read from some relevant textbook. I cannot ask you to go ahead and open and read all big textbook. With a short time in hand, you have to clear the exam. That's what we want. At the earliest, clear the exam, clear paces, get into specialty training, or settle down. So what are the guidelines for surgery in case of asymptomatic primary hyperthyroidism? In a patient with primary hyperthyroidism, which of the following patient you will put in surgery? Anything they may ask. Okay. The first criteria is increased calcium. If it is more than 1 milligram per deciliter above the normal, if the lab normal they give 9 to 11, if the value is 12, then you can put the patient for surgery. That's the first point I want to highlight. Second point, if the creatinine clearance is less than 60, or if the 24-hour urinary calcium is more than 400, or presence of nephrolithiasis, nephrocalcinosis, which is evidenced by ultrasound or CT. This is the renal parameter. Then the skeletal parameter, if T-score is less than 2.5 at lumbar spine, anyway, and age less than 50. All these are criteria for surgery in case of asymptomatic primary hyperparathyroidism. Once again, I'm telling you asymptomatic. Even if the patient doesn't have symptoms, if the calcium level is going to be more than 1 milligram per deciliter, if the creatinine clearance is low, 24-hour urinary calcium is more than 400, any renal stones or calculi, and DEXA less than 2.5, age less than 50, you can push the patient for surgery. Do you need to know the values here, sir? Yes, you have to. Okay. Managing primary hyperparathyroidism, like I said, simple. You treat symptoms of hypercalcemia, anything is there, or any end organ disease, all these things we have discussed, and calcium level is more than 1, you have to refer for surgery. Okay. Other medical management, you can consider 2 drugs, cinacalcet, bisphosphonate. Okay. Cinacalcet is considered with primary hypothyroidism if surgery has been unsuccessful. They will ask you in an MCQ. The patient has been posted for surgery. Even after the surgery, there is no success. The patient having recurring of symptoms, you can go for a cinacalcet. About cinacalcet, the rest of the things has been described nicely in clinical pharmacology lecture. Sorry. Then the other drugs are bisphosphonates. Typically, you give bisphosphonate to reduce the fracture risk, especially in people who are old age or having altered frac score or having osteopenia, you give bisphosphonate. Okay. Types of hyperparathyroidism. This is one table is more than enough. You have a note, put a note, and just follow what I'm going to tell you. In primary hyperparathyroidism, this can be increased or sometimes it can be normal. In secondary and tertiary, it will be increased. If it is tremendously increased, it is always tertiary. One thing. Okay. Second point, this is about PTH. Okay. Don't forget, normally increased, it can be normal, it's primary. Secondary, it is increased. Tertiary, tremendously increased, tertiary. Claro? One point is over. Second point is calcium. About calcium, I want you to know only one thing. Calcium, how you write? Ca2+. 2 is secondary. So in secondary hyperparathyroidism, calcium will be low. Just remember that. Done. You don't need to know anything. Just remember. Just remember that. In secondary 2 for 2, calcium will be low. Calcium, you write a Ca2+, it is low. When it comes to phosphate, it is decreased in primary. Okay. You remember this. P for P. Primary phosphate decrease. Other things, it can be increased or not. Done. Vitamin D, typically it is decreased in most cases. Even if you don't forget everything, the value of calcium and phosphorus can give a lot of clues to you. Calcium is decreased only in secondary. First thing, calcium decreased only in secondary. Next point, phosphate decreased only in primary. You can remember 2 for this 2 and P for this P, or whichever way you want to remember. I hope this is clear for you. This is very important. Next, treatment of severe hypercalcemia. I have another slide that has even, a better thing. I'll quickly tell here itself. You can rehydrate the patient. You can give bisphosphonate. Especially, it's the treatment of choice for hypercalcemia of malignancy. Always remember, in case of a hypercalcemia of malignancy, a malignant patient with increased calcium levels, the treatment of choice is nothing other than bisphosphonate. Then steroids you can give, calcitonin, and oral phosphate also you can give. But they will ask you only one thing. In an acute medicine setup, somebody is having an increased calcium. Immediately what you will do? Rehydrate. Just tell, sir, I will rehydrate the patient. Next thing, if a patient is coming with hypercalcemia and the patient is a known case of some sort of cancer, what you will do? Bisphosphonate. All right, be clear. Now I will show you a video. I want you to tell what condition is this. See this video clearly and make a diagnosis. See this guy's thumb. See this guy's knuckles. What is wrong with his knuckles? What is wrong with his knuckles? See the thumb. See the fingers. See the legs. And now tell me the diagnosis, where you will see something like, see the toes. See the knuckles. and tell me the diagnosis. Yes. Next, knuckles. What is wrong with the knuckles? Tetany. How it is going to be a tetany, doctor? Tetany can occur in this patient in some stages. Hyperparathyroidism. See, two things you found here, right? Undeniably. I'm sorry, I'll write here. Short metacarpal you found. Metatarsals. Okay. Second thing is absence of knuckles. That you will get. This is pseudo-hypoparathyroidism. Okay. This is not McCune-Albright syndrome. It's called Albright hereditary osteodystrophy. This is different from McCune-Albright syndrome. This is called pseudo-hypoparathyroidism. Okay. This is a favorite topic for part 2 people. But I don't know. I have some feeling they may ask for part 1 people also. So if they ask, I don't want you to get scared, because I'm going to teach you some very easy way, like how I taught you for different types of hyperparathyroidism, how to easily diagnose it. Same way, we are going to see few pointers for pseudo-hypoparathyroidism. Nobody's going to treat you the long-term management, follow-up and all these things, because you are not going to get into the field of endocrinology. But you should know few things out of everything. What are the types? There are type 1A. There is a pseudo-hypoparathyroidism. Then is a pseudo-hypothyroidism type 1B. Then pseudo-hypoparathyroidism type 2. Okay. There are a lot of confusing things. Ifs, ands, and buts will be here. So in type 1A, what is the thing? Okay. I'll tell you. First, hypocalcemia. Hypocalcemia seen in all. Okay. I'll write down hypocalcemia is present in all except pseudo-hypoparathyroidism. Got it? You don't need to get confused with this table. Just note down what I'm writing for you. All right? All right? Okay. And serum PTH is increased in all except pseudo-hypoparathyroidism. Okay? Second point is clear. Third point. Again, PTH is increased. PTH we have done. Sorry, 1 second. Again, okay, all right. Then GS alpha subunit, parathyroid hormone receptor subunit deficiency is present in all except pseudo-hypoparathyroidism 1B. Okay. All right. And Albright hereditary osteodystrophy present in all except pseudo-hypoparathyroidism type 2. Okay. At least know this. And one more point finally is PTH receptor resistance not seen in pseudo-hypoparathyroidism and type 2. This 5 points is enough. Okay. They had asked just this 5 points. You don't need to know the table. Hypocalcemia is present in all the type except pseudo-hypoparathyroidism. Serum PTH is increased in all except pseudo-hypoparathyroidism. Means what? If they are giving a case of hypocalcemia with normal PTH, you have to think in terms of pseudo-hypoparathyroidism. GS alpha subunit deficiency is seen in all except pseudo-hypoparathyroidism type 1B. So what it means by that, if they give you a case and they given GS alpha subunit deficiency is there. That is seen in only one condition, that is in type 1B. And Albright has hereditary osteodystrophy, which you have seen in the patient, whom I have shown just now, is seen in all except type 2. And PTH receptor resistance is not seen in pseudo-hypoparathyroidism in type 2. All right. This is the only things I want you to remember. This table can be confusing. Just 5 points won't take much to remember. You can easily memorize. Okay. Now, I want you to tell me the diagnosis of this condition by seeing this picture 1, 2, and 3. 2 is a video, I think. I'll play the video. See number 1. Number 3. What is number 3? How many of you know what is happening in picture number 3? Then I will show you what is picture number 1. Everything I will explain. 1 is Whipple's triad. Fantastic. Number 2 is what? I'll show you the video. Number 3 is what? Number 2 is, you will see this. What is this vision? If you are seeing like this, what is this visual abnormality is called? What is it called, doctors? Tunnel vision you can call. You can also say bitemporal hemianopia, right? Both the side, temporal side is lost. Done. Right, that is there. What is number 3, doctor? Have you seen that? Surgery postings. Surgery postings, who have been to surgery postings. What is this? What they will keep it here? Endocrine surgery unit, anybody worked? Anybody worked in endocrine surgery unit? They'll be able to tell this. What is that? No, that's not thrombophlebitis. Do you know where they will keep the parathyroid gland if they remove the parathyroid? Excellent, fantastic. Yes, that's not AV fistula, doctor. It appears to be like that's a parathyroid gland. Nice. Our doctor has answered. They remove the parathyroid gland for regeneration and again keeping it. They keep it over here in the hands. It's the parathyroid gland. They first displayed this in the international quiz competition. Actually, one of my quiz partner, he was able to diagnose. I got so mad and I was like, hey, idiot, what you are telling, parathyroid gland in hands? Then he explained, because I never got a chance to go and be in endocrine surgery because we were used to posted in surgery only during our internship. And then after started my medicine residency, no point of entering into any surgery. This is a parathyroid gland. Okay, seeing all these things, Whipple's triad, bitemporal hemianopia, parathyroid autotransplantation in forearm, Men's syndrome. Because why? Pituitary, pancreas, parathyroid tumor is Men's syndrome. Got it? Now we are stepping into Men's syndrome. In 5 minutes, we will take a break. I know we all need a break. First is Men 1. Men 1 contains what? Parathyroid adenoma, pancreatic tumor, pituitary tumor. You can read all the thing inside, or if you don't remember everything, at least remember this affects 3 things: pituitary, parathyroid, pancreatic. Okay, just remember these things at least. Men 2, like I said, Men 2A is there, Men 2B, now also it is called as Men 3. The characteristic thing that is seen in both is red oncogene deficiency mutation. Red oncogene mutation cause medullary thyroid carcinoma. Also, along with that, Men 2A has pheochromocytoma and parathyroid adenoma. Okay, pheochromocytoma, we will deal with that shortly. Okay, Men 2B, Men 3, along with pheochromocytoma and parathyroid adenoma, it has other specific tumors, that is mucosal neuroma. And even if you forget everything, remember morphonoid habitus is seen in Men 2B or Men 3. Don't forget. Don't ever forget. Okay, there are 4 M's in Men 2B. That is mucosal neuroma, morphonoid habitus, medullated corneal nerve fibers, and megacolon. Okay, and megacolon. This was my PACES case. When I attempted PACES examination, I got full marks in the station because entering the station, I saw that guy is morphonoid. Then I had some doubt. Then in the history, they gave all the features of Pheochromocytoma. The guy is having AFib and he has also MR, valvular abnormality associated with morphine. That's a meant to be. This is my case. I will never forget this. It's a meant to be. It's my case. Thank you, doctors. We'll go again. Men 4. Men 4, you can find parathyroid adenoma, pituitary adenoma. What is classical for men 4 is reproductive organ tumors. If they give some parathyroid, pituitary, men 3 is nothing but meant to be. Men 2B is also called men 3. That's why I put this slide. Men 2B is also called men 3. Don't get worried if they ask you what is men 3, it's meant to be. What is meant to be? 4 M's. What is the 4 M's? Mucosal neuroma, methylated corneal nerve fibers, morphinoid, and megacolon. Never ever forget. All right. Men 4 is reproductive organ tumor. That is one thing you should remember. Now, can you diagnose the underlying condition here? What is A? So, Men syndrome is clear. This mouse has some peculiar thing. Many of you may not able to understand. This mouse has some peculiar thing on the back. It's a laboratory mouse. It has some peculiar thing on the back. Actually, I had a patient video. Okay. Yeah, it has a stiff back. This is, what is this? We will come in the dermatology. We will discuss this. What is this guy has? All of us men are prone to have these days. Okay, this is alopecia. What is the full name for this? Alopecia, anyone can tell. Even your saloon people can tell. What is this? This is alopecia. Excellent. Alopecia areata. This is 2 types, universalis and totalis. I'll come to that later. Number 3. What is happening here? What kind of treatment she is getting here? What is the treatment, doctor? What is the examination? What is the examination he is doing? No. Just see well what examination he is doing. What is that? As soon as he keeps some, it is fluorescing in some color light. Simple that. I'll show you. This is APS2. Okay. It is APS2. This is vitiligo. It's treated with light therapy. Alopecia is there. Stiff person syndrome. APS is autoimmune polyendocrine syndrome. APS is autoimmune polyendocrine syndrome. Okay. This is an again very important, same like that of your men syndrome. APS1 has your Addison's, diarrhea, ectodermal dysplasia, hypothyroidism, hypogonadism, all these things are there, and type 1 diabetes, splenic atrophy is there. It can be little confusing. Okay. It can be little confusing. But one thing you remember between APS1 and APS2 is APS2 has alopecia areata, which is not in APS1. And APS2 has some peculiar disease like vitiligo is seen here. And some of the things that is very peculiar for this are myasthenia gravis, IgA deficiency, celiac disease. These are all very peculiar for APS2. At least remember this disease, because it is near to impossible to remember all the disease in this column and that column and keep everything in your head. Not gonna happen. It's not possible, to be honest. But at least remember APS2 has alopecia areata, vitiligo, myasthenia, IgA deficiency, and celiac disease, which is not typically seen in this APS1. All right. At least remember that. How questions come from APS1, they may not give you the full scenario and I ask you to diagnose APS1 and 2. That has never happened because it's near to impossible. But in PACES, they will give some scenarios like that. They will just simply bring a lady with just vitiligo, acral vitiligo in her legs or hands, last to diagnose. That's how it happens. This is the difference between this both. This may not be needed. Okay. Just for a safer side, know this. APS1 has something very specific is asplenism and mucocutaneous candidiasis. Here it is more of a vitiligo will be more prominent here. These two are peculiar for APS1. At least know this. You don't need to know the complex stuffs. Don't need to complex stuff. For MRCP1, just to remember these things for a safer side. Okay, this is not a hard and fast rule, but I am afraid what if they ask you? At least remember APS2 has alopecia, vitiligo, myasthenia gravis, IgA deficiency, and celiac disease. Remember, and APS1 has asplenism and mucocutaneous candidiasis. At least remember this 5 lines, it's enough. Now comes to next case challenge. I think now we will take a 5 minutes break. It's good for all of us. And then again, we will come back. Okay, we will take a 5 minutes break. Again, we will come back. Again, we will learn. I'll give you 5 minutes break exactly. We have a lot of slides to go on. We will sit and learn. I'm going to sit and teach. Then only I'm going to sleep. So don't worry about that. Whatever time taken, I'm going to sit and clarify everything and go. We'll take a break for 5 minutes. Okay, take care. Bye-bye. I know it's tough. Dinner time, everything is messed up, but nothing. I have to cover all these things. The reason is I want to make sure all of you get a clear idea of the subject. Otherwise, I don't want to mention there are other fascinating enterprises and people who are teaching past medicine notes. It would be very simple for me to teach you past medicine notes. Just hardly 60, 70 slides. I'll just read by now. I would have been either preparing for my specialty interview or I would have been had my dinner and sleeping and in 7th heaven by now. So, but I want to make sure each and every one here should learn the best. Okay, so it is going to take some time. Bear with me. Next case, 72-year-old man is evaluated for increasing fatigue, bone pain. His medical history is significant for chronic alcoholism, lactose intolerance, and a vertebral compression fracture 1 year ago. He is housebound without any sunlight exposure. He denies any personal family history of kidney stones or fracture or osteoporosis. His physical examination is remarkable for generalized tenderness of the long bones and proximal muscle weakness. He has difficulty climbing stairs with a waddling gait. What is your diagnosis? Somebody has a bone pain. He has increasing fatigue. His medical history is significant for chronic alcoholism. He's having lactose intolerance. Osteomalacia, sunlight difference. Yes, it's osteomalacia. Okay, lot of causes for that. Okay, a lot of causes for that. It can be due to deficient intake of or absorption of vitamin D, or it can be due to defective 1-alpha hydroxylation. One such cause is CKD, you remember. Renal phosphate wasting in RTA, and X-linked hypophosphatemia, Fanconi syndrome, multiple myeloma, so many causes. Even increased in fluoride can cause osteomalacia. This is basic things. Many times this osteomalacia are incorporated in higher secondary studies. But what we need to know, how do we treat osteomalacia? Osteomalacia, if you take, it can be of 2 types. One is oncogenic and another one is non-oncogenic. So how do you treat a non-oncogenic osteomalacia? What is non-oncogenic? An osteomalacia that is not due to a cancer, a bone cancer or any other cancer that is leading to decreased vitamin D. So you give ergocalciferol 50,000 units orally once or twice weekly. This units has been asked. So for anyone who is asking, sir, should I remember the unit? Yes, sir, you have to remember the unit here because it has been asked. They are given 25,000 unit, 50,000, 75,000, 1 lakh. They confuse. So 50,000 units orally once or twice weekly. In case of ergocalciferol, cholecalciferol, also the same unit. Calcium carbonate or citrate, you can give 1 to 2 gram daily orally. Oncogenic osteomalacia is something very different. Here it is due to excessive production of FGF23. What is FGF? Fibroblast growth factor. This is called FGF. It's called fibroblast growth factor. It's due to excessive production of FGF23. It's characterized by markedly reduced serum phosphorus, renal phosphate wasting. It leads to decreased muscle weakness and bone pain. Okay, this complex pathophysiology, you need not know, but the test that will help in detecting the tumor is octreotide scanning. Just to remember, oncogenic osteomalacia can be easily diagnosed with which of the following diagnostic modalities? They could have given anything. Just remember octreotide scanning. It is due to FGF23. Remember, if you are a very fascinating academician, you want to know a lot of things, you can go and read about clothoprotein, how it decreases the renal absorption, how it forms a complex, all those things. But for passing MRCP-1, you need to know FGF23, you need to know octreotide scanning. All right. Here again, you have to give calcitrol as the treatment, 0.75 to 3 micrograms daily. This dosage you may not know, but know calcitrol. And calcium carbonate, same dosage as that of your osteomalacia. So this table signifies the difference between 4 conditions. Leave the renal tubular acidosis. This will be separately dealt with nephrology. Ma'am will take that. Nephrology classes will be really good. So do cardiology classes. Okay. The problem the endocrine is prolonging is endocrine almost covers all the system. It's not a separate system. It almost covers all the systems. So a lot of things are there. It covers your bones. It covers your brain. Everything is covered here. Okay. So it will take some time. So first, vitamin D deficiency. You can find calcium will be decreased, phosphate will be decreased, ALP can be increased as a counter mechanism, and PTH can be increased. Vitamin D deficient rickets type 1 and 2, they asked to differentiate in case of part 2. Okay, in type 1 and 2, the major significant difference between type 1 and type 2 is only one thing. That is 1,2,5 hydroxy vitamin D is decreased in type 1 and it is increased in type 2. Just to remember this. Okay, X-linked, you may not know. But type 1 and 2 differentiation, please know, they may give you a table like this. Just to remember one thing here, that is 1,2,5 dihydroxy vitamin D is decreased in type 1 and increased in type 2. Okay, I may even write 1,2,5 hydroxy vitamin D is decreased in type 1 vitamin D deficient rickets and increased in type 2 vitamin D deficient rickets. Please write it down in your notes. Like what I said for pseudo-hypoparathyroidism, those are the valuable pointers to crack the MCQs. All right. Now we go to the next case. Here a 70-year-old woman presents to the emergency department after falling while getting out of the bed. She fell down after getting out of the bed. She sustained an intertrochanteric fracture of the right hip. Preoperative chest X-ray before repair of the hip revealed she had existing asymptomatic vertebral fractures. So someone with a frequent fractures. Okay, just falling out of the bed, intertrochanteric fracture. What is that? This could be an osteoporosis. It's a common thing, osteoporosis. Yes. Okay, you all know T-score. This is very, very important. How many of you don't know? This is the time to know. These values are important. Yes, it is important. Normal score is more than or equal to -1. Osteopenia is -1 to -2.5. Osteoporosis is less than -2.5, and severe osteoporosis with less than -2.5 plus fractures. All right, you should know normal score more than or equal to -1. Osteopenia -1 to -2.5, and severe osteoporosis -2.5 and below plus fragility fracture. This is the bone scan, bone mineral density scan. It is always matched with a healthy adult. Okay, it is always matched with a healthy adult. This is your Frax tool. This again used in case of osteoporosis. Once what that they have done in MRCP part 1 exam is they mention which of the following is not a component of Frax tool. They asked, I asked one more time, they asked which of the following is a component of Frax tool. They asked, that's why I brought this. I don't have any intention of bringing complex tables and stuff to confuse you or anything, but you should know because they had asked you. All right. What is included in FRAX tool is your age, sex, body mass index, previous fragilities, fracture, parental history, current glucocorticoid treatment, current smoking, alcohol intake. I know it is very tough to remember. I do understand, but they had asked once just to go through that, at least to have some idea about that. That's all I want you guys to know. Okay, it's tough to remember, but they had asked, so I'm bound to show you the slide. Okay, and secondary causes, if there is anything like that, and femoral neck bone mineral density. That's one thing they will find. Femoral neck bone mineral density. So what are the non-pharmacological interventions in case of a osteoporosis? A healthy diet, adequate intake of calcium, vitamin D consumption, and vitamin D rich foods. Also, weight bearing and muscle strengthening exercise. These are normal things. Advice about smoking cessation if he is a smoker, and advice to, and restrict alcohol intake less than 2 units. I hope all of you are aware what is the allowed permissible limit or unit of alcohol intake across the world. It's 2 units. Okay. All right. And false assessment. These are non-pharmacological assessment we can do for the patient. So what is the treatment we have to give in case of osteoporosis? Straight from the NICE guidelines, freshly bagged from NICE guidelines, we are going to see. The very first thing is always offer bisphosphonate. It's the first line treatment. Okay, first point. In case of treatment following hip fracture, always go for IV zoledronate. Already hip fracture is there. Better to admit the patient. IV zoledronate. Also, you have to give all these things in hospital setup, DVT prophylaxis and everything. Okay, always form a multidisciplinary team if denosumab is going to be started, and never stop it without supervision. That is as per NICE. Okay, and if you stop denosumab, start IV zoledronate within 6 months. Okay, once again, first line is bisphosphonate. Okay, in case of treatment following a hip fracture, if they have a hip fracture, they are admitted at the hospital, then go for IV zoledronate. Then denosumab you can go for. Denosumab, if you stop, you have to start IV zoledronate. Okay, then anabolic treatment, what you can give to form the bone. This is to prevent the fracture, anti-resorptive treatment. Then anabolic treatment, what you can give beyond this. Beyond this, you can give, consider teriparatide or romosozumab. Okay, these are the things they can give anabolic treatment to increase the bone mineral density. Just remember that these are the anabolic treatment approved in the NICE guidelines. Okay, no need to know everything. Just remember this thing, that is more than enough. And about bisphosphonate, some of the adverse effect in clinical pharmacology, you have to advise if they have a GERD, they may likely to have a GERD. So ask them to take the tablet, sip a glass of water, and sit supine posture, sit in the erect posture at least for 30 minutes. That is one of the advice you have to give. And bisphosphonate also can cause jaw necrosis. Denosumab again can cause this jaw necrosis. And denosumab, another adverse effect you should be aware of is they can cause atypical fractures also. Okay, they can cause atypical fractures also. All right, the next question. A late middle-aged woman presents with chronic right hip anterior thigh pain. Okay, increased localized temperature is there. Lately, she needed a walking stick. During the past 6 months, her relatives have noticed progressive hearing loss and some facial changes with enlargement of mandible. What is the diagnosis? Quickly tell me. What is the diagnosis, doctors? Hip pain, hearing loss, facial changes is Paget's disease. This is the Paget's disease of the bone. What is the peculiarity of the Paget's disease? Is Paget's disease, there will be bone formation, bone destruction. Bone formation, bone destruction. Ultimately, destruction of the bones. Bone formation and bone destruction is the Paget's disease. This is the picture of a Paget's disease, a Pagetoid skull. Okay. Overall, Paget's disease, what are things can happen? It can cause cranial nerve compression due to the skull deformity. Second cranial nerve can compressed. Eighth cranial nerve can cause deafness. Fifth cranial nerve can be compressed. Seventh cranial nerve can be compressed. Cardiac hypertrophy and high output failure. This is very, very important. What kind of cardiac failure you get in Paget's disease? They had asked. It's high output failure. You should also know the causes of other causes of high output failure if they ask in MRCP. That is Paget's disease, thyrotoxicosis, beriberi, everything you should be knowing. Arthritis it can cause. It can cause classical bowing of legs. And one more classical finding in case of Paget's disease is limb length discrepancy. You make the patient lay down straight, both the legs will not be in the equal proportion. One leg will be slightly shorter than the other. That is called seen in Paget's disease. That's a limb length discrepancy you will find in Paget's disease. Okay. Rarely carcinoma that can affect Paget's disease is osteogenic carcinoma. This is a Paget's disease. This is a hip fracture. See the bowed legs. If you just make the patient lay down normally, you will find a discrepancy between these two limbs. That is called limb length discrepancy. Okay. This is again a lateral radiograph of Paget's disease. So, what are the things about Paget's disease? Once again, for part 2 people, these are the bony changes. What can happen? Bone can expand, cortical thickening can be there, and osteolysis will be there. This will lead to bone deformity and loss of distinction between cortex and medulla, osteosclerosis, trabecular thickening. All these things can happen in Paget's disease. And in biochemistry, you will find raised total ALP with normal liver function test. That is a characteristic feature. Total ALP will be raised where that liver function test will be normal. So diagnosis, typically you are going to do a radionucleotide bone scintigraphy along with other x-rays. Okay, along with the other x-rays, you are going to do this. And serum total ALP recommended as a first-line biochemical test in combination with liver function test. Okay, that's about Paget's disease. So some of the bisphosphonate, what are being used in current clinical practice is given here. Their dosages, if you are interested, go through it. No need to remember this for MRCP-1. Okay. So what is the difference in between all these three combined? It is given there. You don't need to look at this and get confused, because this hyperparathyroidism and hypoparathyroidism we dealt separately. Paget's disease, only thing you remember is increased ALP. Osteomalacia, osteoporosis, there won't be any such weird findings and all. Don't go behind findings. Osteomalacia, you know, calcium will be decreased or maybe normal, but ALP will be increased. Okay, now comes to hypercalcemia. We have seen about hypercalcemia and management. So causes of hypercalcemia, we know lot of things are there. Okay, lot of things. But what they will be one such thing is milk alkali syndrome. Okay, one such thing is called as milk alkali syndrome. These people who take a lot of antacids, they may develop something called as milk alkali syndrome. This is one of the cause of hypercalcemia that you should be knowing. This causes you can go through, but what I am most interested is one particular entity. In case of hypercalcemia, how do you typically manage a patient? Typically, in any patient with hypercalcemia that is more than 14 milligram per deciliter, you have to immediately begin the treatment. Okay, the first line treatment is what? Always going to be your IV fluids. The next thing you have to do in case of a hypercalcemia is review the medications, repeat total calcium level. If the hypercalcemia is still there in spite of the treatment, you have to take 3 tests. That is PTHRP, 1,2,5 dihydroxyvitamin D, and 2,5 dihydroxyvitamin D. This is what UpToDate says. Here, the thing I want you to know is the role of PTHRP, parathyroid related hormone, that is called PTHRP. Why it is very, very important in case of a hypercalcemia is if it is present, it is always associated with hypercalcemia of malignancy. Okay, hypercalcemia of malignancy. Okay, this one point at least you know from this table. Now I will tell you what are the treatment options for hypercalcemia in general. What are the things we will give stepwise. First is always going to be your isotonic saline hydration. They will ask in the MCQ, a patient is coming with hypercalcemia. What is the next step you will do immediately? The next step you have to do immediately is hydrate the patient, hydrate the patient, hydrate the patient. There is nothing will help you better than the hydration. That's the step number one. Step number two, you can give calcitonin. Okay, what calcitonin do? It stops the bone resorption. Clinical pharmacology, the role of calcitonin in hypercalcemia. What is the mechanism of action? It inhibits the bone resorption. Number three, you can give bisphosphonates, which just does the same. Number four, loop diuretics. It increases the calcium excretion. Number five, glucocorticoids. Six, denosumab. And ultimately, if nothing works out, it's going to be dialysis. This is how you approach a hypercalcemia patient. But always remember, it doesn't matter what happens. The very first treatment is isotonic saline hydration. But if they ask, okay, if they ask what you're going to do in case of a patient with hypercalcemia of malignancy, I told you what will be elevated here, PTHRP. Okay, in that case, if they ask you, directly go for bisphosphonate. Yes, doctor, why not bisphosphonate after hydration? That's how we go in case of hypercalcemia of malignancy. Normally, we try calcitonin before bisphosphonate, but in case of hypercalcemia of malignancy, the straightforward treatment is bisphosphonate. There is nothing you can do here. Okay, now comes two important topics we are going to discuss here. I know it's getting late, but these are very, very important topics, so we cannot ignore this. Okay, even if I teach little less of diabetes mellitus, you can still survive, because diabetes mellitus is a common thing. You could have encountered everything, but disorders of sexual development is very important, because a lot of MCQs are being asked in this. Okay, now we are going to the next topic, a quick review of disorders of sexual development. Come on, who is going to answer this question? A 13-year-old girl is brought to the pediatrician by her mother, who is concerned about a short stature, lack of any signs of pubertal development. Her 11-year-old sister is 10 centimeter taller and already has a breast development. Parents are average in height and puberty at the age of 12 and 13. So parents are normal, sister is normal. Past history is significant of frequent otitis media. Physical examination reveals a short girl, 135 centimeter, weight of 55 kg, mild hypertension. And remainder of the examination, tannin staging, no need to worry. Multiple melanocytic nevi is there, as well as high arched palate is there. What is the diagnosis? Short stature, delayed puberty, melanocytic nevus, high arched palate. Yes, it's the Turner syndrome. Excellent. This is the Turner syndrome. They're not going to ask you Addison's disease. No, doctor, that's not here. We will talk about Addison's disease in a while. Okay. So you should know the criteria to diagnose a Turner syndrome. That is typically a narrow palate or a high arched palate, broad neck, webbing of neck. They can give anything out of this. Short stature. Okay. Absence of pubertal development. Common cardiac defects include bicuspid aortic valve and coarctation of aorta. These are the common things. If you find all these things in one particular patient, then you should know you are dealing with a Turner syndrome. Got it? Next, a girl is born in short time after normal pregnancy. On examination, she noted to be hypotonic, hyperextensible joint, small ears, small mouth, protruding tongue, broad neck, upward slanting of the eyes, and a single palmar crease. These are been asked in MCQ. What is the diagnosis? Single palmar crease is the characteristic feature. Where you will get it? Fantastic. This is the Down syndrome patients that you can see later also. This is Down syndrome, single palmar crease. Okay. Now, combining everything together, we are going to quickly review about different sexual developmental disorders. Okay. First thing, trisomy 21 is Down syndrome. What you need to know? Okay. Karyotype, 47. And What are the features you should know? Flat face, slanting eye, epicanthic fold, and simian crease. That is a single palmar crease. Short, stubby fingers and hypotonia. Variable learning difficulties will be there. That is down. Number 2, trisomy 13 is your Patau syndrome, 47 plus 13. Low set ears, there will be cleft lip, palate and polydactyly, typically microophthalmia and polydactyly. These 2 points noted down for trisomy 13, that is Patau syndrome. They may ask trisomy 18 also, that is Edward syndrome. Here again, low set ear. Here the classical thing is rocker bottom feet and learning difficulties. The characteristic feet you will find is called as your rocker bottom feet plus learning difficulties, that is your Edward syndrome. Are you all clear? Now next go to Fragile X syndrome. Okay, that Fragile X syndrome, the characteristic feature I want you to note down is macroorchidism. Typically people used to tell some bold people, this guy actually got balls, right? That big balls. Macroorchidism, because enlarged testicles will be there. That is characteristic and a specific feature in case of Fragile X syndrome. That's how you need to learn. Learning difficulty, short stature can be there in anything, but I want you to learn something very specific. Trisomy 21 Down syndrome, specific simian crease or single palmar crease. Trisomy 13, specific microphthalmia and polydactyly. Trisomy 18, that is Edward syndrome, specific thing is rocker bottom feet. Fragile X syndrome, the specific thing is macroorchidism. Turner syndrome, you will know. Triple X syndrome, they call it as a super female. We heard of it, super female. Triple X. They are the most notorious, many of the notorious serial killers in female women. Women serial killers are rare, but most of them are the super females. Triple X syndrome. Klinefelter syndrome, you all will be knowing. Okay, still I will tell. Decreased crown and pubis heel ratio, you no need to know that, but typically no gynecomastia, testicular atrophy, infertility. Tall guy, if they tell, it's going to be Klinefelter syndrome. What if the syndromes come with non-specific presentation? They will not give you like that. They will give at least one thing which I underlined there. Non-specific, they won't ask you. The non-specific they ask in SCE examination. That is specialty certificate examination, not for you. Then next question. 17-year-old girl from a traveler's family comes to clinic for review. She's concerned that she may not be entering puberty as she has no secondary sexual hair development. There is past history of bilateral inguinal hernias, which were repaired on infant. On examination, she is 167 centimeter in height. BP, BMI is okay. Normal looking breast, no pubic or axillary hair. So what kind of problem you are dealing with here? A 17-year-old girl, they are bringing it to you. Okay, no secondary sexual hair development. She is 167 centimeter tall, no pubic or axillary hair. And I just boxed some point that is extremely important that will give you the diagnostic clue here. That is bilateral inguinal hernia. Once again, bilateral inguinal hernia. What is it? Androgen insensitivity syndrome. Who has told? Fantastic. Okay, the characteristic thing here is this bilateral inguinal hernia is typical for androgen insensitivity syndrome. Why it is? This bilateral inguinal hernias are nothing other than testis. What is cryptorchidism? What is cryptorchidism? Cryptorchidism means undescended testis. This testis will be undescended and present in the inguinal head region as inguinal hernia. All right. If you find it, this is called androgen insensitivity syndrome. All right. Now we will go. It happens in 1 in 1046XY individuals. There is resistant to androgen. That is called androgen insensitivity syndrome. All right. Usually inherited from the mother. There are 2 types. Complete androgen insensitivity syndrome and partial or incomplete type. Complete is there will be a complete female phenotype. Outwardly, she will look like a proper girl. Normal breast development due to aromatization. That's what NICE says. What is aromatization? testosterone is converted to estrogen by means of an enzyme called aromatase. That is called aromatization. That's why we have some drugs to stop that called aromatase inhibitors. We have some drugs to stop that called aromatase inhibitors. Okay. We have some drugs to stop that called aromatase inhibitor. You are getting it? We have some drugs to stop. That is called exemestane, anastrozole, lestrozole. So due to this aromatization, the female will be completely female. She will look like a proper female. There will be normal vagina here in case of complete androgen insensitivity syndrome, but there won't be any uterus with scanty and pubic hair. An inguinal hernia will be there that contains testes. Are you clear? Then gonads are usually left till the breast development. Then risk should be wait for malignancy, because any cryptorchidism and an undescended testis is a high risk for malignancy. Okay, it's a high risk for malignancy. You're getting it? There is a high risk for malignancy, so you cannot leave it as it is. All right, one thing. Next, there is something called partial androgen insensitivity syndrome, also known as Riefenstein syndrome. First thing, complete, I told you how it is. Female phenotype, she will be fully like a female. Okay, testis will be undescended. It will present as an inguinal hernia, and gonads are usually left till the breast development. Then this should be wait for malignancy, because I told you cryptorchidism predisposes malignancy. Partial, what happens in partial? Here also there will be phenocrotal hypospadiasis and undescended testis. Here there will be gynecomastia present at the time of puberty. Okay, at the time of puberty. In partial, the risk of gonadal cell carcinoma, that is GCC, gonadal cell carcinoma risk is tremendously high. Okay, next case. 16-year-old, previously healthy female, presents with acne, presents with hirsutism, irregular menses. Her pubertal history reveals breast development at 9 years of age and pubic hair development at 7 years of age. She reported 1 episodes of vaginal spotting, approximately at 11.5 years of age. A family history indicates some female relatives with symptoms of infertility, irregular menses, polycystic ovarian syndrome, alopecia. She is significantly shorter than her target height. Okay, what is the diagnosis? Sorry, where is the defect to deal with adrenal gonads, or there are not sensitive to androgen? The sensitivity, the problem here will be more in the gonads. Okay, more in the gonads and also adrenal. Here, what is the diagnosis? Is it PCOS? Really? This is congenital adrenal hyperplasia. Of course, lot of things about PCOS is there. But PCOS females, will she be short? No. Many PCOS females are normal looking. Now we are taking a study where PCOS people not even having a metabolic features of obesity and all, they are looking normal. Okay. So there are 3 types here when it comes to CAH. This table will save you from the differences. 1, 2, 3. First is 21 hydroxylase. Second is 11 beta hydroxylase. Third is 17 alpha hydroxylase. Any of these enzymes can be affected. First thing, make it clear. Any of these enzymes can be absolutely affected. So, in case of aldosterone, it is decreased in 21 and 11 beta hydroxylate, but it is increased in 17 alpha hydroxylase. Androgen is increased in both, but it is decreased in 17 alpha hydroxylates. And blood pressure is increased in both 11 beta and 17 alpha hydroxylase, but it is decreased in 21 alpha hydroxylase. And always remember, whenever there is an increased potassium, BP will be low. Whenever the potassium is decreased, BP will be, whenever the potassium is decreased, BP will be high. Whenever the potassium is increased, BP will be decreased or normal. So in 21 alpha hydroxylase, potassium is increased. As a result, BP will be decreased. Where in 11 and 17, potassium is decreased. As a result of that, BP will be increased. This 21 alpha hydroxylase classically present as salt wasting. Once again, I'm coming to the table. This is very important for part 2 and as well as part 1 people. There are 3 deficiencies: 21 alpha hydroxylase, 11 beta hydroxylase, and 17 alpha hydroxylase. In case of aldosterone, it is decreased in first 2 and it is increased in 17 alpha hydroxylase. In case of androgen, it is again increased in 21 and 11 beta and is decreased in 17 alpha hydroxylase. One more thing I want you to remember is the blood pressure. Okay, I'm repeating, doctor, the blood pressure. Whenever there is an increase in potassium, there will be decreased in blood pressure. Know that? Now, potassium is increased in 21 alpha hydroxylase, so the blood pressure is going to be decreased. Potassium is decreased in other 2 forms, so the blood pressure is going to be increased. And one more point is 21 alpha hydroxylase present as a salt wasting syndrome. All right. Management, simple thing: give hydrocortisone, fluorocortisone. Sex steroids, mineralocorticoids, glucocorticoids has to be replaced. Again, in non-classical, glucocorticoids has to be replaced, and growth hormone or GnRH analog can be given, and OCP can be given. Okay, OCP can be given for hirsutism. All right. Now we are going to next case. What I'm going to do is I just need just 2 to 3 minutes break. I just need to change my router switch. I just need 2 to 3 minutes break. We will take, we have around another 50 slides. We will try to wind up in next 35 to 40 minutes from now. Okay. I'm just going to take 2 to 3 minutes of you break. Just excuse me. I'll just change my router for a better connection. Please stay here and we'll be back in just 2 to 3 minutes from now. Okay. Can someone confirm? You guys can hear me well? Is my audio clear? Can someone confirm whether my voice is clear here? Or you have any voice disturbance? I just have to switch over the router. That's why I want to confirm with you all. Hello? Can anyone confirm in the chat? Okay. Okay. Thank you. Thank you. Thank you so much. All right. We have another 50 slides. There is nothing we can do. We have to finish endocrine. We have to go through all those things. Okay. Now the next question. 35-year-old woman has not resumed menses since stopping OCPs 1 year ago. She reports normal puberty, regular menses before and during her use of OCP. She had one normal pregnancy with a spontaneous vaginal delivery 3 years ago. She has no significant medical history except for mild hypothyroidism. Furthermore, she has no significant medical history, and she has also noted occasions of episodes of vaginal dryness and irritation, and feels occasionally as if someone has turned the temperature up in the room. Sexual intercourse has become increasingly uncomfortable. A physical examination demonstrates atropic changes in the vagina. A pregnancy test is negative. What could be this? She had pregnancy, she had a kid, she had normal menstrual cycle, and it stopped. And the first thing to rule out is always going to be what, whenever there is a woman coming with menstrual cycle stop, they will ask you, menstrual cycle is not coming for 3 months. The first thing you have to do is urine Gravidex test or pregnancy test. Okay, pregnancy test. Here the lady is young, relatively young, 35. So this is going to be a premature ovarian failure. The most common cause of premature ovarian failure, they had asked once, idiopathic. There will be raised LH and FSH level. This will give you a clue. If there is a raised LH and FSH level, and they are giving a history of a lady who was earlier menstruating and suddenly the period stopped, it can be premature ovarian failure. How do you treat? You have to treat with hormone replacement therapy. So, can anyone interpret this particular USG and tell me what is this? Can you see? Can you tell me what is this? What are you seeing here? Yes, excellent. You guys are diagnosed. This is a polycystic ovarian syndrome. So criteria of PCOS, there are a lot of criteria. They stopped asking criteria because there is always controversy between one criteria and other criteria. There is a Rotterdam criteria, there is androgen excess society criteria. Okay, typically there will be features of hyperandrogenism. There will be features of ovarian dysfunction. Okay, these two things you remember, plus cysts in the ultrasound. Also be aware, these people, many of these people has a metabolic phenotype. What is a metabolic phenotype? Typically acne, hirsutism, obese, all these things will be there, obviously. But that's not true, because we have now started taking a study where we found a lot of women, young, thin, without any metabolic features, having PCOS. That was surprising. Okay, and no glucose intolerance, nothing is there. Still they have PCOS. Okay, so now comes to one thing that is very important: amenorrhea with uterus and outflow tract. How do you approach? This is very important. Okay, this slide is extremely important. First, okay, if you find a female with amenorrhea, there is a normal uterus and outflow tract is there. Okay, if the uterus and outflow tract is normal, okay, you're going to find a USG scan, she has a normal vagina, normal uterus. Okay, first thing, like I always tell, check beta HCG. If they ask in MCQ, what is the very first thing you will be checking is beta HCG. If it is positive, it's pregnancy. If it is negative, check only one hormone, that is FSH. If FSH is normal and patient is having amenorrhea, then you can think in terms of hyperandrogenism like a PCOS or a 21 alpha hydroxylase deficiency or a tumor. Getting it? If FSH is normal and amenorrhea is there, then hyperandrogenism or 21 alpha hydroxylase, and the diagnosis could be PCOS. If the FSH can be normal or low, then you can think in terms of any pituitary pathology. If the FSH is going to be high, like I said, it is going to be any premature ovarian failure or a Turner syndrome. Suppose the outflow tract or a uterus is abnormal, then you have to immediately do a karyotype. If the karyotype is abnormal, karyotype is what you are doing a chromosomal studies. If it is abnormal, then it can be androgen insensitive syndrome or 5-alpha reductase deficiency. If the karyotype is going to be absolutely normal, then it can be due to Müllerian agenesis or imperforate hymen. These are all OG related stuff. Just know if the karyotype is normal, uterine and outflow tract is abnormal, then it has to relate it with some gynecological issues. That's all you need. Nobody's going to ask about Asherman syndrome, Seneca formation, and everything. Just know this, how to approach amenorrhea with the uterus and outflow tract. Then lipoprotein metabolism disorder, few things I will teach you. The management of hyperlipidemia will be dealt in cardiology. Okay, that one thing I will tell you, that will be dealt in cardiology. Okay, these are the type of apolipoproteins you should know. But what you should be knowing here, what they will ask you here is certain things. What is the source? Intestine, every lipoprotein is produced in the liver, but in intestine, always remember Apo A1, B48 and C3. Remember, for basic sciences, these three things are formed in the intestines. What are they? A1, B48 and C3. These three things are seen in the intestines. Always remember that. Always remember. These three things are very, very important. Okay. Next, this table will save a lot of issues. Okay, this table has everything you need to know about the lipoprotein metabolism and lipoprotein metabolism disorder. The very first thing we will come to now. Okay, familial chylomicronemia. Okay, what happens here? You don't know about gene mutation, it's perfectly fine, but you cannot afford to know what is, you cannot afford to miss out not knowing what is actually happening with the lipoprotein metabolism. If there is a familial chylomicronemia, there is increased chylomicrons, VLDL and decreased HDL. And the most important things they will give and ask you in the MCQ is the clinical feature. This will lead to pancreatitis. eruptive xanthoma and hepatosplenomegaly. This is autosomal recessive disorder. Once again, familial chylomicronemia. The name itself says chylomicrons will be increased. There will be decreased HCl. What clinical feature is most important, because they will give a scenario based on the clinical features. So what you find here is your pancreatitis, eruptive xanthoma, and hepatosplenomegaly. This is an autosomal recessive mode of inherited disorder. The second thing is familial hypercholesterolemia. Typically, you will find elevated LDL. Here, in this case, you will find a premature atherosclerotic cardiovascular disease. Once they had given a case of someone around 30 years of age, he is having an MI. And his father, when he is around 35, he had an MI. Like that history. And highly elevated LDL and decreased HDL. You have to think in terms of familial hypercholesterolemia. And one more very, very important point I want to highlight is this familial hypercholesterolemia is autosomal recessive disorder, whereas the rest of all the dyslipidemias are an autosomal recessive disorder, where this alone is an autosomal dominant disorder. Okay, just remember all the familial hypodyslipidemia are autosomal recessive except familial hypercholesterolemia. Then third disorder is familial beta lipoproteinemia. Here there will be elevated chylomicron and IDL. Here the characteristic feature is called palmar tubuloerrative xanthoma. This palmar xanthoma is characteristic feature of familial beta lipoproteinemia. Just to remember, palmar tubuloerrative xanthoma, characteristic feature of familial beta lipoproteinemia. Then there is something called A beta lipoproteinemia. Here LDL will be absent, TG will be decreased, and HDL will also be decreased. Here spinocerebellar and retinal degeneration will be there. For namesake, you need to know that there is nothing we can do. Next comes this fascinating Tanger's disease. This has been asked multiple times. This Tanger's disease patient will have something classically called orange tonsils. They will have red-orange colored tonsils. They had once given a patient scenario with red-orange colored tonsils. Which condition you will find is your good old Tanger's disease. All right. Here HDL will be nearly absent. Elevated TGs will be there. Here neuropathy and hepatosplenomegaly will be there. Then LCAT deficiency, just go through. That's it. These are the very important ones. I want all of you to remember the clinical feature, because based on the clinical feature, they will ask you what it is. If you know the clinical feature, you will be able to answer. And one important thing, like I said, familial hypercholesterolemia is autosomal dominant. The treatment part of the dyslipidemia will be extensively covered in cardiology session. Okay, now comes to another case. 42-year-old man undergoes transphenyl surgery. I'm sorry. Yeah, 42-year-old man undergoes transphenyl surgery for a large non-functioning pituitary macroadenoma. Preoperatively, dynamic pituitary hormone tests were normal, as is fluid intake and output. 2 days following surgery, he developed acute polyuria, extreme thirst. His urine output over the next 24 hours was 6 liters with frequent nocturia. What is the diagnosis? So what has happened here, doctors? A gentleman is undergoing a transphenyl surgery. He was fine till then. After getting the macroadenoma removed, what happens here? After getting the macroadenoma removed, he is having a increased urine output and frequent thirst. Hungry bone syndromes, not Hungary, doctor, it's hungry. Think. Then this is a case of diabetes insipidus. This is a case of diabetes insipidus. Pituitary related post-pituitary surgery. No, definitely not hyperglycemia. Why hyperglycemia? Suddenly he will develop. Hyperglycemia, this polyuria will be there for quite a long time. This is a diabetes insipidus. I want all of you to know. Orient yourself. I know it is getting late. I know it is getting late, but still just orient yourself. Some more time, we will pull it up. Come on, we can do it together. This is a diabetes insipidus. Okay? Polyuria following a transphenyl surgery. This is diabetes insipidus. So 3 things they will ask you. Just watch the table very carefully. 3 things very carefully. This is straight from NHS. Okay, 3 things they will ask you. You should be able to know the difference between these 3 things. That is primary polydipsia, central diabetes insipidus, nephrogenic diabetes insipidus. What are the three things? Primary polydipsia occurs when a guy just gets thirst, or when the guy gets some psychological disturbance. He keeps drinking water more and more and more and more till he pees enough all his sodium and water. That is a primary polydipsia. This will be seen in an anxious individual or someone who is having some psychological disturbance. They'll have that. Central diabetes insipidus is what? You have a pituitary gland. You have an anterior pituitary and posterior pituitary. The hormone, that is arginine vasopressin, if it is going to be decreased in secretion, that will lead to dilution, and that lead to central diabetes insipidus, characterized by excessive thirst and excessive urination. Nephrogenic diabetes insipidus is what? Your kidneys has receptors for vasopressin. When they are affected, it's called nephrogenic diabetes insipidus. As a result, the person will pass more and more urine without concentrating. So how do we differentiate between these three if they are not giving any history? This case, they have given a history of the patient have undergone some pituitary surgery. If there is no such history has been mentioned here, what you will do? No such history has been mentioned here, what you will do? So that's where you have to interpret using the values given here. The very first value is serum osmolality. In case of primary polydipsia, it will be decreased. But in case of central and nephrogenic diabetes insipidus, it will be increased more than 300. First point. Second point, urine osmolality. It will be more in case of primary polydipsia. What is urine osmolality? It will be more in case of primary polydipsia. Okay. If you give a water deprivation test. Okay. If you give a water deprivation test, that is, if you deprive the patient from drinking water, it will be more. Why it will be more? Patient won't be drinking any water. As a result, the urine will be concentrated in case of primary polydipsia. But if you deprive the patient from water, will the urine be concentrated in central or nephrogenic? Absolutely not, because his pituitary is not, posterior pituitary may not be functioning. So urine is not going to get concentrated. So urinary osmolality will be decreased. And nephrogenic diabetes insipidus, will it help? No, it will be decreased. Then third parameter is post-DDVAP, that is after giving arginine vasopressin, what happens? In a primary polydipsia, there won't be any change because this is nothing, there is no pathology there. So even if you give that, there is not going to be any change. But in case of a central diabetes insipidus, there will be significant increase in osmolality because the problem is decreased secretion of arginine vasopressin. Once you give that externally, it will go and act on the kidneys and it will concentrate the urine. So post DDVAP, urinary osmolality will increase in case of a central diabetes insipidus. In nephrogenic, there won't be any effect either because why? Nephrogenic, the problem is with the receptors in the kidney. So how much ever DDAVP you give, it is not going to work out. All right. All of you clear with these three tables? This is very, very important. So many questions are based on this. Okay. So once they had asked when you will stop the water deprivation test, now I don't think they are going to ask because this test is not being used extensively as per my endocrinologist. If there is a weight loss more than 5%, or if serum osmolality reaches more than 3 milliosmol, and if there is any symptomatic dehydration, you have to stop the test. But now it's unlikely. What are the latest things in diabetes insipidus? They have a very simpler way to differentiate between nephrogenic and cranial DI is to measure basal plasma arginine vasopressin as well as urine osmolality. If the basal plasma AVP is more than 1 and urinary osmolality is low, then it's always nephrogenic. Now they are directly measuring AVP, but still questions are based on this table. So be very clear, be ready to face it. I hope all of you clear. I hope none of you have any doubt in this. Okay. Pituitary bright spot is always present in primary polydipsia. That's just to knowing. Okay. Now I'm going to go straight to the condition, that is SIADH. What is SIADH? That is syndrome of inappropriate antidiuretic hormone secretion. You all know that. So what is the criteria? This criteria has been asked in multiple ways in multiple times. So you should know the criteria. What is the criteria? True plasma hypoosmolality, that is serum osmolality should be less than 280. Criteria number 1. You should remember the value? Yes, you should here. Secondly, urine concentration inappropriate for plasma osmolality. Just know that. Number 3, clinically euvolemia in the absence of diuretic therapy. That is, patient is not showing any signs of shock. Number 4, no evidence of renal sodium conservation. Urinary sodium should be more than 30. And number 5, normal thyroid and adrenal and renal function. This criteria is called Schwartz criteria. This is what we use in UK for SIADH. That is, true plasma osmolality. Serum osmolality will be low and patient will be euvolemic. At least know these few things. And urine sodium will be always more than 30 and normal thyroid and all the other function. If they give any scenario like this, always think in terms of SIADH. So how do you manage SIADH? There are 2 types. One is acute. If the patient is having acute SIADH, maybe in your ICU or ward, always give hypertonic saline and fluid restriction and find out the underlying cause. Later point of time, you can add furosemide. Okay. In case of chronic SIADH, again fluid restriction. In this chronic SIADH, you can give tolvaptan, a V2 receptor antagonist. If tolvaptan is not helping, you can give furosemide. If furosemide is not helping, demiclocycline. Okay, you should know the flow of treatment. So in chronic, first you are going to give fluid restriction. If not working, you are going to give a tolvaptan. If tolvaptan is not helping, you have to give a furosemide. If furosemide is not working, you have to give demiclocycline. They will ask you in any stem here, they will ask you fluid restriction has been initiated, it's not helping. Next, tolvaptan. Tolvaptan has been given, not working, furosemide. Furosemide is not given, not working, the patient is still having decreased serum osmolality, then you have to go for demiclocycline. Just remember that this is the thing. In acute, you have to always give a hypertonic saline and fluid resuscitation. Now, can anyone tell me what is the diagnosis here? It's a young guy and the entire family has a history of some diabetes. This is pancreas. What is this? Quickly, because now we come to the most fascinating topic, diabetes mellitus. Yes, we are going to diabetes mellitus. I'll quickly tell you the things which you need to know. Okay. Yes, this is a Modi diabetes. Okay, this is a Modi diabetes. These are the different types of Modi diabetes. Okay, different types of Modi diabetes. All right, and you should know certain things. That is, Modi 5. Why it is? This is a diabetes with renal cyst and pancreatic cyst is there in case of the Modi 5. That is one thing I want all of you to know that. Okay, types of Modi, basic sciences. If you want, I'll add a slide, just go through that. But modify, you should know that. And modify, another thing I want you all of you to know is it's a defect in the fructose transporter. Okay, it's a defect in the fructose transporter. Always know that it's a defect in the fructose transporter. Okay, it's a defect in the fructose transporter. That's one thing you should know. And modify, also you should know this. Know about modify is it has a cyst. If they give anything like pancreatic cyst, this, that, and all, where it is occurring, then you should be knowing it is modify. No other thing will have this thing. Okay, that one more thing that you should know. And another thing I want you to know is the enzyme that is deficient. Modi 1 is due to HNF4 alpha, like it's mentioned. They had asked once. Okay, Modi 2 is GCK. What is GCK? Glucokinase. Modi 3 is HNF1 alpha. This they had asked. At least remember these 3 things. Okay, at least remember these 3 things. Modi 1 is 4 alpha, 1 is 3 is 1 alpha, 4 is 1 is 4 alpha, and 3 is 1 alpha. And Modi 2 is glucokinase deficiency. Okay, and modify is fructose transporter defect, which has cyst. And coming to one more thing in diabetes which you need to know is, I'm just going to tell you what is essential, because I'm not going to sit and teach the entire diabetology, which will be just time consuming and won't be any fruitfulness for you. Certain things which is important only we are going to go. Management of DKA, they have given asked multiple times. Okay, confirm the diagnosis. That is the first thing. That is increased serum glucose, beta hydroxybutyrate, and metabolic acidosis. This will be there. But there is an entity called, I want all of you know, called euglycemic DKA. That is, serum glucose will be normal, but still DKA will be there. You know where you will find? You will find in patients using SGLT2 inhibitors. Those patients will have euglycemic DKA. Then what's the next thing you have to do? Quickly send electrolytes, RFT, and admit to ITU. Then replace with normal saline, because I hope all of you know, I'll quickly tell you. And then start insulin therapy, 0.1 units per kg, and correct the potassium. Okay, correct the potassium. Then once this is corrected and glucose levels and start coming back to normal, then you can start subcutaneous insulin. Just remember that. First, verify, confirm the diagnosis, send the electrolytes, RFT, and admit to ITU. 3, fluid replacement. 4, insulin administration. 5, potassium correction. At least know this, because I believe most of you would have cleared this, done this in your hospital. Okay, this is a recently proposed classification of diabetes mellitus in American Diabetes Association conference, especially in 23rd. If you guys are interested, just go through that. Okay, otherwise this is not a hard and fast rule, neither it is going to be asked in your part 1 right now. Okay, now coming to diabetes mellitus. Okay, how you are going to treat the patient with diabetes mellitus? This matters a lot. These are certain slides from NICE guidelines. Straight away screenshot from NICE. Okay. First thing, always remember, in any patient with diabetes mellitus, always lifestyle modification comes as a first choice when it comes to UK. After lifestyle modification only, you will be starting on any sort of treatment. They are not going to pump you with drugs like how they are doing in other countries in UK. So what they are going to do? If lifestyle modification is not helping, or if they ask you, there is a patient with impaired glucose and he is obese, whatever it is, then he is not at high cardiovascular risk, then metformin is the first line. If there is a GI disturbance with metformin, modified release metformin, please don't go and choose anything like I'll give a PPI coverage or I will change the drugs. If there is any GI disturbance with metformin, the next step is modified release metformin. Then you have to check for chronic heart failure or any other thing. If the patient is having any heart failure, always remember SGLT2 inhibitor is the choice. Okay, if the patient is having any heart failure, always remember SGLT2 inhibitor is the choice. Okay, just these 2 points you take home from the slides. First is lifestyle modification. If the patient is not at high CVD risk, but still lifestyle modification is not going to help anything, metformin. If the metformin induced GI disturbance, please don't tell anything, I'll stop metformin or jump to sulfonylurea. NICE recommends modified release metformin should be tried. If there is any heart ailment, SGLT2 inhibitors. All right. Okay. SGLT2 inhibitor. Along with that, you can add up certain drugs. If that is not helping, you can add sulfonylurea. These are the adding treatment, or a DDP4 inhibitor. Particularly, if you want to go for a weight neutral drug, you can add a DDP4 inhibitor. Pioglitazone we are not using much, because frequently they ask the adverse effect of pioglitazone. Pioglitazone can cause sodium plus water retention. It can worsen the heart failure. Okay, remember this. Diabetes mellitus is very simple. Learn some basics, that's enough. Pioglitazone, you are not going to add in any patient with heart failure. Typically, you avoid the drug as much as possible. If it is not controlled with metformin and as well as your dapagliflozin or any SGLT2 inhibitors, you can try a sulfonylurea provided the patient is not obese, or a DDP4 inhibitor which is weight neutral. Okay. Then if all the triple therapy fails, then you can go for insulin therapy. But in the same side, there is another treatment called GLP-1 mimetic drugs. This is your, all GLP-1 mimics are your liraglutide, your exenatide, all these drugs. So when you will give a GLP-1 agonist, that they had asked multiple times, NICE clearly says two things. Okay, if there is a body mass index of more than 35, you have to start a GLP-1. First criteria. Second criteria, they asked when you will start a GLP-1 agonist. Even suppose, for example, some patient is having body mass index of 33. See, for example, some patient is having, some patient, if he or she is having BMI of 33 or 34, will you start a GLP-1 agonist? Still yes. In suppose if they have any obesity related comorbidities, or insulin therapy would have significant occupational implications. For example, the patient is a driver. He cannot keep on standing and putting insulin, or he cannot avoid, he cannot afford to get hypoglycemia episodes during the time. Or if the patient does not want insulin at all, then you can suggest GLP-1 agonist. Okay, it has a good weight neutral and weight loss effect as well. Okay, so they ask you what is the criteria for starting a GLP-1 agonist. They had asked in the MCQs. There are three things. First, if there is a BMI of more than 35, you will start. Or if the BMI is 33 or 34 with obesity related comorbidities, maybe the patient is having hypertension or any cardiac ailments, then you have to start GLP-1 agonist. Okay, these are the drugs and some contraindications. DDP1, DDP4 inhibitors, that is allogliptin, linagliptin, are contraindicated in case of ketoacidosis. Okay, in renal impairment, dose reduction should be there, and hepatic impairment, dose reduction should be there in case of gliptins. In case of metformin, it is contraindicated in metabolic acidosis, because metformin itself can cause lactic acidosis. All right, renal impairment, I will tell you how to reduce. Pioglitazone, it should be avoided as per NICE in ketoacidosis and history of heart failure. And also it can cause bladder cancer. Very, very important adverse effect. Pioglitazone can straight away cause bladder cancer. All right, just remember that. This adverse effect you should know. This rest of the adverse effects have been clearly discussed with clinical pharmacology. Then comes your GDM, gestational diabetes mellitus. Now you need to know who are at risk of gestational diabetes mellitus. Anyone with BMI above 30, previous history of macrosomic baby, that is called a Pedersen hypothesis. What is a Pedersen hypothesis? Pedersen hypothesis, what will happen due to maternal hypoglycemia, what will grow is IGF-1 will increase. That is insulin-like growth factor. This will cause increase the head circumference of the baby, that will cause a macrosomic baby. Okay, this is called Pedersen hypothesis. In any case of family history of diabetes, previous history of GDM, or an ethnicity prone to diabetes, glycosuria 2+1s or 1+ more than twice, all are risk factors. The reason I put the slide is not to bore you. They had asked, among the following, who are at the risk factor or getting gestational diabetes mellitus, you should be able to tell. Okay, that's the reason I put the slide. So diagnosis is, how to diagnose a GDM? If the woman has a fasting plasma glucose level of 5.6 millimole or a 2-hour plasma glucose of 7.8. This is the latest diagnostic criteria for GDM. We also do OGTT as well. Okay, next, treatment in case of gestational diabetes, diet and exercise. You can add metformin. Earlier days, they said metformin is not used. Metformin should not be used in case of gestational diabetes mellitus. Nothing like that. You can add metformin. Okay. If fasting blood glucose still going to remain above 7, then you have to add insulin plus or minus metformin. So you should know how to approach gestational diabetes mellitus. First, diet and exercise. Second, a trial of metformin. If the fasting blood glucose is more than 7, then insulin plus or minus metformin. In case of pre-existing diabetes, or HbA1c more than 48, then you have to start mostly insulin. Okay, and always in case of pre-existing diabetes in pregnancy, retinal screening should be done on 16th and 20th week and again on 28th week. Just remember, they may ask you. All right, and the choice of mydriatic is tropicamide. Just remember these things. And pregnant women, when has to be referred to the nephrologist, and MCQ has come based on this slide. That's why I am bringing the slide here. In case of creatinine 120 or more, urinary albumin creatinine ratio more than 30, total protein excretion more than 0.5, all these things you have to refer the pregnant lady to the nephrologist. Okay, just remember that, and never use EGFR to measure kidney function in pregnancy. That's one more thing. Insulin therapy is just some general slides. You can go through that, and adverse effect. Okay. Only one thing I want to tell you here is, in insulin therapy, if they mention something as a patient on insulin getting frequent hypoglycemic episode, what you will do, just the next option we will do clinically is going for a insulin like insulin glargine, that is a long acting insulin. Remember this thing, that should be more than enough. Okay, remember this thing, that should be more than enough. This is one of the things they will ask frequently on insulin. Nobody is going to ask you insulin dosage. The sliding scale questions from past test are outdated. I will come to that. Okay, then fasting. Okay, fasting with diabetes has been frequently explored in so many ways in MRCP Part 1 and Part 2 papers. So who are at risk, at very high risk when it comes to fasting, that you should be knowing. People with type 1 diabetes mellitus are at very high risk when it comes to fasting, because they will need insulin, they cannot prolongly fast. And people with type 2 diabetes of HbA1c more than 8.5 are at risk. And people with hypoglycemic unawareness, one such drug that can cause this is beta blocker. That means the patient won't have any symptoms of hypoglycemia, but his blood glucose levels will be adamantly going low to a dangerous level. Okay, or severe or recurrent hyperglycemia in 3 months before Ramadan or any other festival that requires fasting, that patient is in high risk. Or any history of DKA or hyperglycemic hyperosmolar coma 3 months before any festival, again problem. Anyone with CKD, heart failure, acute illness, pregnant woman, all are very high risk when it comes to fasting. So how do you approach a patient who has to fast with a diabetes? Okay, all patients should always break the fast under 3 conditions. This has been asked. If the blood glucose is less than 70, if the blood glucose is more than 300, and symptoms of hypoglycemia and hyperglycemia are dehydration. Just remember 3 values when to break the fast immediately is 70, 300. Just remember, if the blood glucose level is less than 70, the patient should break the fast. And if the blood glucose level is more than 300, patient should break the fast. Or any symptoms of hypoglycemia, hyperglycemia, dehydration, break the fast. This thing you should know. So how do you give a oral agent in a fasting? Metformin, the daily dose completely remain unchanged. Okay, what they typically recommend is OD take at iftar and BD at iftar and suhoor. This is straight from NICE guidelines. Okay, this is the typical regimen. If there is a prolonged release, take it after iftar. Okay, sulfonylureas we no longer recommend in UK nowadays, but only metformin is recommended. This is an endocrine question. Okay, no need to worry about insulin. They ask frequently on metformin. How do you change the dosage? Okay, and sulfonylurea they have to take. You have to switch to newer sulfonylurea like glycoside or glycoside, because glibenclamide can cause decreased blood glucose very easily, and the frequent monitoring should be there. Okay, so there is no point in discussing on that, but metformin is the ideal drug to give anyone in the fasting. Okay, OD, take it iftar. That is the prolonged release metformin at iftar is the best thing you can do for a fasting patient. Okay, these are insulin sliding scale. Okay, insulin sliding scale dose If you want to know, if you have a patient, you have to prescribe for fasting. These are the values. This UK, we have something called Daphne. That is dose adjustment for normal eating. For based on the blood glucose levels of the patient, they themselves can enter the blood glucose levels, and the particular software can tell you how much insulin has to be taken post-iftar and pre-iftar. These are certain values which will be of some help. Okay. Now we are going to come to another case, that is a 63-year-old woman. Just we have 20 slides. I'll be winding up in 20 minutes. 63-year-old woman with severe degenerative osteoarthritis of the knees underwent total right knee replacement without immediate complication. She has a history of atrial fibrillation for several years and on oral anticoagulant therapy and beta blockers. Oral anticoagulant therapy was discontinued before surgery. She was placed on intravenous heparin. 2 days after starting heparin therapy, she became fatigued and her supine blood pressure decreased from preoperative value of 122 to 90. Post-op, decrease in blood pressure. Most common cause is going to be nothing other than your adrenal insufficiency. Signs and symptoms of adrenal insufficiency are a lot, starting with orthostatic hypotension, salt craving, dizziness. Okay, and it can be due to mineralocorticoid or glucocorticoid deficiency. But what matters most is going to be how do you differentiate between it's a primary or a central adrenal deficiency. Okay, that's what matters. This we are going to explore right now, and after that few more slides we will going to wind up. Okay, so if you find anyone having adrenal deficiency, I will ask you one question. Okay, a central, that is a pituitary or a peripheral adrenal insufficiency. Who is going to answer me? Just by looking at the patient. Okay, you are not going to do any test. Just by looking at the patient, how will you tell this patient having central deficiency, this patient is having peripheral deficiency? Just by looking at the patient. You're not going to do anything. Just by looking at the patient, how will you tell? Exactly. Excellent. How? Fantastic. Yes. In central adrenal insufficiency, you will get something called alabaster skin pigmentation. I have a patient I thought of showing, but anyways, we are using the video for patients, so I didn't put it up here. Peripheral, there will be hyperpigmentation. Just remember this. All right. So how do you differentiate between primary and central adrenal insufficiency? If the patient having cortisol deficiency and all the symptoms. Okay. Cortisol deficiency, once it's verified, check for plasma ACTH. If the ACTH is above the upper limit of the normal range, okay, the ACTH is increased, then it is going to be primary. Okay, so this is pituitary gland, this is your adrenal gland. If ACTH is going to be tremendously increased, what it means? There is no negative feedback. So the problem is with the adrenal gland. If the ACTH is below the normal limit, always know this is going to be central. At least in MRCP level, know this. If you want to know little more intermediate and all, you need not know. At least know these two extremes. Okay. If in endocrine level, if you want to know upper half of the normal reference range, they will also measure plasma renin and plasma aldosterone. If aldosterone is low with elevated renin, then it is again going to be primary adrenal insufficiency. Just these 3 points, you know. ACTH is tremendously increased, means there is no negative feedback going from the adrenal gland. It is going to be a primary adrenal insufficiency problem with the adrenal gland. If ACTH is low, then the problem is with the pituitary, that is the central adrenal deficiency. 2 points. Point number 3, if the renin is high and aldosterone is low, again it's going to be primary adrenal insufficiency. Just know these 3 things. Then they may ask you how to know the etiology of the primary adrenal insufficiency. How to know the etiology? What is the cause for the primary adrenal insufficiency? That has been asked in part 2. Part 1, they may not. Just I will brief you very quickly. Okay, in patient with confirmed, you have confirmed a primary adrenal insufficiency. Okay, that is the ACTH is tremendously increased. You have confirmed. The first thing to rule out is ask whether the patient is taking any adrenotoxic drugs, that is mitotane, ketoconazole, or metirapone. Remember these drug names because this can cause adrenal insufficiency. If they are taking this drug, yes, that is drug induced, no problem. If they are not taking the drugs, then you have to measure autoantibodies, especially 21 hydroxylase autoantibodies. If it is present, it is an autoimmune. Okay, if it is present, autoimmune. If it is present with other autoimmune, that is APS. Done. Okay, if the antibodies are negative, okay, if the antibodies are negative, you have to measure something called very long chain fatty acid, VLCFA. That is called very long chain fatty acids. If they are present, then something called adrenoleukodystrophy is present. This has been asked in part 2. If the patient with adrenal insufficiency with elevated VLCFA, it is adrenoleukodystrophy. Please, part 1 people, at least know the names because they may ask you in the worst time, they may ask you. Okay. If antibodies are negative, you do the CT scan of the adrenal glands, then see what it is. Okay. Once again, I'm coming to you. I told you if ACTH is increased, then it means primary adrenal insufficiency problem with adrenal gland. If ACTH is low, it is going to be central pituitary cause. Clear? Now, if the renin is high and aldosterone is low, it is again primary. Now come to how to approach the primary. I said, if the patient is taking any drug, first rule out mitotane, ketoconazole, or metirapone, then it is going to be drug induced. If not, measure autoantibodies. Autoantibodies are positive, it is autoimmune. If autoantibodies are negative, then think of taking VLCFA, very long chain fatty acid, okay, especially in males, then it is adrenoleukodystrophy, it is common. If it is negative, take CT scan. Just, are you all clear up to this point? That's more than enough. Then type of insufficiency and specific treatment you need not know. Just know what do you do in case of an adrenal crisis. In case of adrenal crisis, how do you treat the patient? This has been asked. Just establish to large IV cannula and send the investigation. And first thing to do is isotonic saline is the very first thing you have to give. Saline infestation, then immediately you have to give hydrocortisone. Just remember, admit the patient, saline infusion with hydrocortisone simultaneously. That's why they call 2 large IV access they typically take. You have to give that simultaneously. Then based on the other things, you can give steroids, or then you can give other mineralocorticoid supplementation if it is needed. Just know these 2 points. Okay, this everything is given clearly. This table you may not need, but I want you all to know how to differentiate between these two, how to approach a primary adrenal insufficiency. That should be more than enough. Now comes to another case challenge. I'll go straight to the diagnosis. Time is getting so far away. This is a pheochromocytoma. You know the pheochromocytoma. Typically, patient, they will give you present with headache, palpitation, and all the things. Okay, there's a list of symptoms is given here. So, what is the test that you have to do? Which test has more sensitivity and specificity? If they ask the best test with the highest sensitivity and highest specificity for a pheochromocytoma is going to be either a DOPA PET or a DOTA TEC scan. This is proven beyond any doubt. It is given even in the NICE guidelines. The test with highest sensitivity and highest specificity are these 2 tests. Initially, you give 24-hour urinary total metanephrines are the first test you will do. You can do CT and MRI. But the most sensitive and specific test they had asked in MRCP-1 recently, 23, DOPA PET CT or DOTA TOX scan. Always remember, these are the most sensitive and specific test and the most appropriate test. If they ask you what is the next test you are going to do, initial test is going to be 24-hour urinary fractioned metanephrines or anything you can tell. Okay, that is about pheochromocytoma diagnosis. Treatment, the treatment is going to be complete tumor removal. Okay, Adrenal cortex should be preserved here to avoid adhesions. BP maintenance is 160/90, and I hope all of you know the cause. I had explained in clinical pharmacology. Phenoxybenzamin alpha blocker should be given before giving beta blockers. Okay, first phenoxybenzamin should be added before giving beta blockers, and nowadays we have multitude of myriads of endoscopic procedures. Okay, this is about Pheochromocytoma. Remember two things. The first initial test is always going to be total metanephrin or fraction metanephrin, but the most sensitive and specific test is either Dopa PET CT or Dotatex scan. And treatment, removal, first you give alpha blocker, then you give beta blocker. That's how you remove. Then there is a term called metastatic pheochromocytoma. This term typically they use for pheochromocytoma. Earlier they called malignant. This is the pheochromocytoma that has another distant invasion. Okay, typically seen in von Hippel-Lindau syndrome, SDHP, and as well as RET oncogene mutations. This three things is more than enough. This is some images. This is a syndrome. You can guess it. I'll quickly tell you. There is a tumor in cerebellum. This is a retina. What is the diagnosis? This is a tumor in renal system. Renal system, retina, and cerebellum. Which condition has tumors in all these things? Quickly, in 10 minutes, we'll wind up. Absolutely, this is von Hippel-Lindau syndrome. It typically causes retinal angioma, hemangioblastoma of cerebellum, multiple pancreatic cyst, also renal cyst also it can cause. If you get all these things, it's von Hippel-Lindau syndrome. Only once they had us, so I want you to remember. Now we come to the last topic, obesity. These are the symptoms, syndromes that is associated with obesity. Just I want you guys to just go through. It is very straightforward. It is written. What are the syndromes? This will be taken in clinical sciences, but still I wanted to give a gist of it. That's why I added this slide. You can go through. And this is a classification of obesity. Underweight is someone less than 18.5. The healthy weight now recommended is 18.5 to 24.9 BMI. But to be honest, Asians, they recommend a BMI of 22 for us Asians. Overweight is anyone between 25 to 29, you know, and obesity is 30 to 34. Obesity grade 2 is 35 to 39, and morbid or extremely obese is someone more than 40. This table you should know. This values should I know, sir? Yes, you have to know. Okay. This is waist circumference based. In South Europeans, if you know, waist circumference normal, men should be, cutoff point is 94 and women 80 in Europeans. In South Asians, 90 and 80, not 94. Okay. The reason why the bar is little relaxed for Europeans is Europeans tend to have more of a peripheral fat than visceral fat, where we tend to have more of a visceral fat than the peripheral fat. That is one thing. Okay. Approach to obesity. So obesity related questions have come. The last 5-6 slides we have come to. Okay. So just try to focus something. There are a lot of drugs that can be given for obesity. Just I want you to know everything. Okay, because anything can be asked. So pharmacotherapy should be started when the BMI is more than 30 or more than 27 with complications. This is the first thing you should know. Always for anything we start with calorie restriction and exercise, but pharmacotherapy BMI more than 30 or more than 27 with complications. Okay, there are a lot of drugs. First is a centrally acting drugs. Centrally acting drugs, there are a lot of drugs that acts on the hypothalamus by promoting satiety, because our satiety center is in hypothalamus. If you give the drugs, they will feel full even with very little food. Okay, that's the first thing. First drug is pentyramine. This is combined with topiramate. It is approved for this use. Okay, pentyramine with topiramate. This pentyramine topiramate can cause renal stones. Topiramate especially. Remember that. The next drug that is approved is lorcaserin. Remember, this acts on 5-HT2B, but it was withdrawn now due to cardiovascular and carcinoma risk. Then other drug that is approved is naltrexone and bupropion. In the centrally acting drugs, you know the mechanism of action. Okay, this again controls obesity to some extent. Other agent which they will ask you is orlistat. Okay, orlistat is a very important agent because it is a pancreatic lipase inhibitor. It inhibits pancreatic lipase A2. Okay, then the adverse effect of orlistat are there will be fecal urgency or mucod or oily stools. These are the most common adverse effect. Other adverse effect is since it decreases the pancreatic lipase, the fat will be decreased. Fat soluble vitamin absorption can be impaired. Okay, impaired. Typically, you can ask psyllium or muciloid husks to decrease this adverse effect. And do you know what is this called? Any idea? Gelesis and plenty. This Gelesis is a oral device. It's a water-soluble capsule. If you once take this Gelesis capsule, it goes and absorbs, occupies. If you take this capsule, if this is your stomach, this capsule will go and absorbs around 25% of your stomach. So there won't be any chance of people eating. This is one of the advancements in obesity. And when it comes to indications for surgery, when you do a surgery in case of obesity, BMI is more than 35 or BMI more than 30 with comorbidities. Okay. How surgery helps? Surgery increase the satiety and increase the incretin effects. As a result, not just it will control the obesity, it will nearly reverse diabetes as well in such patients. These are different types of surgery, just for namesake, if you want to know. There is another surgery that is recently being used called intraluminal gastric balloon. If you put that balloon here and it inflate it, it will occupy most of the stomach, so they won't eat much. And this is an interesting thing about genes and obesity. They had asked in MRCP-1 only once about genes and obesity. Okay. One thing I want you to remember is high ghrelin, low leptin and adiponectin will lead to increased calorie intake, which will further increase obesity. Just remember the hormone ghrelin, leptin, adiponectin. Increased in ghrelin, decrease in leptin and adiponectin will cause increased calorie intake and obesity. Okay, just to remember this point, even if you don't remember the entire list of things, how the receptor is there, how people are obese, what research they did, that's fine. Just remember high ghrelin, low leptin and adiponectin will lead to increased calorie intake and obesity. That's the one thing. And with this, I'm winding up. Thank you so much. I think we started at 8. We nearly went around for 4 hours, but there is no other go. I'm extremely sorry if I made a lot of people wait for quite a long time, because this is the only way we can cover the most of the endocrine. Like I said, I am speaking to the management. If there is any way I can sit and work with all the past test and past medicine MCQs related to endocrinology, it will be better, because once for all, the subject will be over for you. So after that, if you go back and work it out and go through the lectures again, it will be just a cakewalk for you. That's what I'm speaking. Let us see how things are. I want all of you, please leave some feedback, some good feedback in the groups, whichever group you are coming from, in the WhatsApp groups of our MedXM expert. That will encourage us to bring more and more session, okay, to cover you and help you with MRCP. And thank you so much, everyone, and you are most welcome. Please, I want to see some good feedbacks from you all, so that we'll come back with some more and more innovative sessions. Thank you so much, and all the very best. Okay. Yes, you have to go through past test and past medicine question bank. And about the seminar, I don't know. I just suggested. Okay. I'll just let you know.